Good morning, everyone. Can somebody give me a thumbs up in Zoom land if you can hear me? Okay, great. Thank you, Mary. Okay, I think we're ready to start.
One second, Jason. I'm gonna do the transcript. Okay, I'm ready.
Okay, go ahead, Brian.
All right. Good morning. Calling to order the January 22nd, 2026. Kind of crazy. It's 2026 already. VbBS meeting. Holly Jo is out, and so I'm stepping in for her today. So the first item on the agenda is basically around conflict of interest. So if anyone has any conflicts of interest that they need to let the group know about, please let us know now. Okay, hearing none, I'm going to pass the meeting off to Jason, who's going to give us an introductory orientation and update.
All right. Go ahead, Liz. Welcome to the VbBS today. Just as a reminder of our purpose here today,
Hey, Jason. Sorry to interrupt. Should we roll first?
Oh, we can do that. Sure. Go ahead.
Okay, thank you. Brian Duty.
Present.
Adrian Irwin.
Here.
Max Kaiser.
Here.
Lucy Langer.
Present.
Sarah Love.
Here.
Mike Collins.
Present.
Ben Hoffman. Antoinette Awachi. I haven't seen her come to the meeting yet. Mary Ongrove.
Here.
David Sanger.
Here.
And then Holly Jo Hodges is absent, as is Chris Pinzon. We have quorum. Thank you.
Thank you, Daphne.
Yeah, Ben is joining VbBS today, but he must be running late. Something going on. Okay, I'll go forward with the orientation then. So as a reminder again, OHA set a goal to eliminate health inequities by 2030. Our purpose here today at this subcommittee meeting is to make coverage recommendations for the Oregon Health Plan. These decisions will affect over 1 million OHP members, as well as their families, caregivers, and providers. So that's well over 250,000. PERC makes policy decisions and cannot approve or deny any individual requests for care. These are population level decisions. For those of you new to our process who may be attending, staff has prepared some recommendations which we'll present, and then members will be discussing the proposals and reflecting on public comment. VbBS, the subcommittee may approve or modify the recommendations, but they are not final until approved at PERC. Usually that'll happen this afternoon, although PERC has the option to delay or make a different decision. And they will be implemented at later dates. In most cases today, that later date will be October 1st, 2026. We do have a couple changes that we wanted to implement earlier, and so we're planning on implementing those on February 1st, and we'll specify those as we go through. In general, the considerations include the committee's assessment of the balance of benefits and harms based on the best available evidence and some other factors. Also, patient values and preferences, stewardship of public resources, and the nature of our delivery system. And underlying all of that, of course, as I said at the beginning, is our health equity goal. Next slide. Some logistics and housekeeping. If you're attending online, if you're a member, please be on camera and attend and let us know if you need to step away or need to go off camera, but are still listening so we can keep track of quorum. Looks like we need to update our slide. Please message Daphne or Tracy, who I'll introduce in a moment, or Chelsea, Chelsea Pritchard or Tracy Hewlett, or Daphne if you need help. Members of the public, votes will be by roll call. We no longer use the chat. Please speak up or raise your hand rather than using chat if you want to speak. It's hard to watch the chat when facilitating. We have one person offering verbal testimony, so we'll ask them to change their Zoom name to make sure it matches the registration name. That'll be later in the agenda. And other participants can use the Q&A feature to ask questions to staff. We'll do our best to answer those, but depending on what you ask, we may have to follow up tomorrow after the meeting. It's just there's a lot to keep track of during the meeting. The chat and Q&A are part of the public record. The meeting is recorded and will be posted. I'm sorry, we've had a change on that. Again, we need to update that slide. The meeting will no longer be posted online. I'll explain more about that in the staff report. We're joined by Ben Hoffman, a new member, and we've got a couple of other membership changes, which I'll announce in a little bit. Next slide. And as always, feedback, if you don't want to use the Q&A, best way to contact us is herc.info@oha.oregon.gov. If it's something that doesn't need to be taken care of during the meeting, I recommend that. All right, that is all of that.
Great, thanks. All right, the next item on the agenda is going to be approval of the minutes. The minutes for the previous VbBS meeting are.
Excuse me, those are on page 10.
Page 10, yeah. Thank you. Excellent. So hopefully all of you have had an opportunity to review the minutes. Are there any items that you'd like to extract for discussion for the minutes?
Or any corrections or errors?
All right, hearing none, I would entertain a motion to approve the minutes as written in the packet. Do I have a second?
Second.
Okay. Daphne, are you going to do the roll call? Or
Sure.
okay.
Happy to. Thank you so much. Antoinette, has she arrived? No, thank you. Well, let me scan this real quick. Oh, there she is. Welcome, Antoinette. Mary Beth Ongrove,
Approve.
Ben Hoffman,
Yes.
Adrian Irwin,
Here I am. Sorry, it was doing its rounds. So I'm here now.
thank you so much. Max Kaiser,
Here. I mean, yes, sorry, jeez. Not late.
Lucy Langer,
Approve.
Sarah Love,
Approve.
David Sanger,
Yes.
and Brian Judy.
Yes.
Motion passes. Thank you.
And did we get Antoinette's vote
Collins.
or Mike Collins?
Oh, I'm sorry. He's not on this list. Mike Collins
Approve.
and Antoinette.
Adrian, did you vote? I think we may have a problem with our list.
I approve. My name
I
got called
approve.
right as I think Antoinette was checking in, but I approve. That's fine.
I approve as well.
Now this.
Okay,
Now we do. Thank you all.
The motion passes. The minutes have been approved, so I'm going to turn the floor back over to Jason, who's going to give us the staff report.
Yes, so as you have noticed, if you've been paying attention, we've got some membership changes and we're gonna have some more planned. David Sanger has resigned. This will be his last meeting. Thank you, David, for your service over the last few years. And
Sure.
all the best on your future endeavors. We've also got some new members joining this committee. Mike Collins and Ben Hoffman have been on the HERC for some time, but have joined this committee. I believe both of you were on it prior. You weren't. Oh, I'm sorry. Ben was on VbBS and Mike was on VbBS. And glad to have both of you back at the last meeting. And did I miss any other membership changes? I think that is all. So excited to have that. We've also got a couple of new members. Jeff Fortner is now seated at HERC, and Linnea Lindsay has moving. And Adrian has moved off HERC. We've also got a new member under recruitment. Katie Schaubel has left HERC and VbBS. And we've got Abby, oh, that's right. And we'll have a vote today about appointing Abby Kahn to replace David, so we'll have continued cardiologist representation on the ERG. Or sorry, this summer. So I think that's everything else for membership for right now. We also have some staff changes. I'd like to welcome Tracy Hewlett to our team. She's joining us as a program analyst. She will be helping us with some process improvement and some of the duties that Liz Walker has been doing now that Liz is part-time. So welcome Tracy. She's got a great deal of experience. I think she's the senior member of our team as far as experience with OHA and just has done a lot of different roles over the years. So we're glad to have her. Also Chelsea, who joined us this fall, will be going on maternity leave any day now, but probably not more than a week. And so Tracy will be helping to back up her, and that'll help with the process improvement. So please watch your email. If you see Tracy Hewlett, she's one of us. And Tracy, can you just briefly introduce yourself, get your voice in the room? So
Yes, I'm Tracy Hewlett, and I'm actually looking forward to getting to know all of you and work with you. So I will keep it short and sweet.
Okay.
Yes.
Thank you. All right. Next news is a change. This will be our last meeting at this location due to the budget cuts, which has just been trying to take its belt in all kinds of areas. This isn't a huge expense, but they're trying to do it consistently. We are looking into options for having in-person meetings at a state office building, either in Portland or Salem. We'll be reaching out and polling and deciding where to do that or whether to alternate. Just part of the times we live in and trying to be responsible with our resources. So as a part of that, this will be the last time we'll serve lunch. So we might get a DoorDash group together or something, where people can bring their own. We also have an errata. Liz, can you give the latest on that? I know it was evolving last night.
Yes, so we have several changes, mainly around the CDT codes that you all approved back in November for 2026 placement. Unfortunately, it's my mistake of using the prior list, and due to the renumbering, the biennial report, some CDTs got cross-mapped onto, I don't know, myeloid something, leukemia, pleurisy, right. So that's been corrected. You'll see on a change log will be uploaded today or tomorrow. And there is, here's pleurisy, and now it's back onto where it's supposed to be. So you'll find that in the change log as well as in this errata.
Yeah, so these are the new dental codes. So apologies for that error.
And it was also my error for some of these topics being developed using the October 1 list.
Yeah, so we'll continue to work at getting our processes better. It gets confusing around a biennial list because the line numbers change. Thankfully, this will be the last time that happens because of the benefit update project. Update on coverage guidances. We have one going on hypoglossal nerve stimulation. That's in the evidence-based guidelines subcommittee that a new device was approved by the FDA. So we're going to delay that. Another meeting of VbBS, it'll still come to HERT by May or so, I'm guessing. And then we've also they're starting a coverage guidance on terminology is evolving, disposable insulin pumps, tubeless insulin pumps. There's a variety of technologies, and so that'll be going through the evidence-based guidelines subcommittee and eventually come your way. We also continue with the benefit update project. That work group has completed and made its recommendations. There is a legislative concept being proposed in the House Health Committee. We also just got word last night. There were some questions about whether OHA could continue status quo with the prioritized list. And CMS confirmed that that is not an option to use the funding line as a way to reduce the benefit package for budget cuts. Again, we don't know what the legislature will do, but just giving you the information we have at this time. We also have some changes to our public comment survey. Daphne, if you could briefly review those.
Absolutely, thank you. As part of my new role as a public affairs specialist, we took a look at what our comment forum did for us and made some changes to make it more user-friendly for us and for people who are coming to us to comment. Some of the changes include adding the advanced public comment to the comment survey and the ability to sign up for verbal comment at that time rather than asking people to come back a second time to sign up for verbal comment. The announcement that our comment form was not functioning was a little premature. It is working. I just had a filter on it, so my bad. But it seems to be working really well. I've got some positive feedback on it. And if you have any questions about what we're doing or how it looks, I'm happy to answer them. Thank you.
The other change, we had some people asking for their comments to be distributed to you all, but not posted publicly. We changed that. All comments will be posted publicly. We did retain an option for people, if they're including public health information about themselves or another person, to be anonymous and have their name redacted. We do have that option to preserve anonymity, but in general, unless that scenario applies, we will be posting all comments publicly going forward. Which reminds me, there is also a bill in the legislature. It's an omnibus bill. It's a super long bill, has many parts. It also has some provisions related to our public comment process. It would not allow us to change our agenda after 14 days prior to a meeting, which normally would not be a big problem, but occasionally late-breaking stuff happens, so it could delay implementation of important decisions. So we've reached out to the people behind that, and we're working with them on that to make sure we can do our work and we address, we give adequate notice and public comment to those affected by decisions. I think that is all for legislation. Port group changes to the public comments. Oh, and one other thing about dental codes. There's two dental codes, CDT 9924 and 9925, which are anesthesia with advanced airway related to dental service. OHA decided there are CDT equivalents billed under the medical side, and so OHA will not be opening those for payment, and they wanted us to announce that here. So any questions, feel free to reach out and we'll get you to the right person to address that. And finally, just a reminder, as you speak, please remember to identify yourself, especially if you're in the room, because it can be hard to tell who's speaking, and just speak loudly and clearly. And be mindful of people having their hands up, and we'll make sure everybody has a chance to speak when they want to. And just also consider whether to speak again if there are others who want to speak. Just be mindful of a balanced conversation. We do want your opinion, but we want everybody to be able to participate. That is all I have.
All right, thanks, Jason. Any questions or comments? All right, okay, we'll move on to the straightforward consent agenda. Ariel.
There were two codes on our just straightforward code. One was just moving forward a decision from BUP a little earlier. One was kind of matching some codes. Any questions? You want to discuss any of those?
Starting on page 54.
Thank you. And then we had a whole bunch of guideline note changes. Most of these were simply a clarification or sort of one of them kind of pointed to another guideline because of some confusion in the genetic testing. We added a couple codes to our genetic testing for malignancy line. We also added a reference to the dental periodicity schedule, our preventive dental care. And you had the periodicity schedule in your packet. And this is something that CMS is requiring for dental programs. More administrative. Lymphedema, we kind of just tried to clean up some stuff because of some confusion in the guideline. Any questions or concerns? Anyone want to discuss any of those guidelines? And then Heidi, do you want to talk about just quickly do your couple sentence update on ABA for IDD?
Yes, thank you so much, Ariel. So you'll find in your, can you hear me okay? It sounds like I'm getting feedback. It's okay. Okay. You'll find in your packet an update on what was done. So there's an issue summary summarizing that. This was a look at ABA for those with intellectual and developmental disabilities noted as IDD in the documentation. We have an evidence map from the Center for Evidence-Based Policy, as well as a review of how we would consider a type of single case experimental design, or SCED, in the context of HERC in the kind of review that we did. So that is all there for your review. Happy to clarify anything needed.
Okay, is that it for the? Okay, all right. Hearing, well, actually, sorry, I would entertain a motion to approve the consent agenda as presented.
So moved.
You have a second?
Second.
Okay. Daphne, can you do the vote?
If I can find my mute button, I'm happy to do it.
Did you?
I can jump in.
I got it. Brian
okay.
Duty.
Sorry, actually,
Daphne, 1 second.
Daphne, I'm sorry, my error. There was one item missing from the annotated agenda. That's the forcible foreskin retraction. We had a public comment from an advocate, and it really seemed to be more medical training and sort of general care of uncircumcised boys. However, we did find that there was one code, foreskin manipulation with lysis of adhesions, which is currently, it is currently on a couple lines. It would be appropriate for phimosis, but not for the redundant pupus. So that was the only recommendation, removing it from the redundant pupus line.
Okay, any?
Apologies.
Yeah, no problem.
Did you have a question?
Yeah.
A revised motion then to
Yeah.
approve that?
Yeah, I was gonna,
Yeah.
so.
Thank you.
So moved.
Okay. All right, do we have a second? Second. Okay, great. All right, Daphne, sorry about that. You're up.
That's all right. Thank you so much. Antoinette Owachi.
I approve.
Thank you. Mary Beth Ongre.
Approve.
Ben Hoffman.
Approve.
Adrian Irwin.
Approve.
Max Kaiser.
Approve.
Lucy Langer.
Approve.
Sarah Love.
Approve.
David Sanger.
Approve.
Mike Collins.
Approve.
And Brian Duty.
Approve.
Did I miss anyone? Motion passes. Thank you.
Okay, great. We're gonna turn it back over to Ariel, who's gonna give an update on 2026 HICPIC codes.
So
That's on page 135.
thank you. As you are, you may or may not be aware, CMS releases HICPICs quarterly. This is our January set. Most of them were pretty straightforward, and there was an Excel spreadsheet with the different codes. Most of them had very similar CPT codes. So HICPICs are generated by CMS, CPT codes by AMA, and when the two don't agree, especially on the RVU, sometimes they'll issue their own CPT codes. Happy to talk about any of these. There's a care management for behavioral stuff that's ancillary. There were a but there were two things that were pulled out just as a, mainly because we needed more information for you all. The first was coronary angiography with coronary lithotripsy. We reviewed coronary lithotripsy in March of 2024 and determined that it didn't have sufficient evidence of effectiveness. And so we will be adding the new HCPCS codes to the E2 entry that has the CPT code. The second issue was team remote E&M codes. It is unclear what CMS intends these to be used for. They may be for a specific provider type. There are already codes for like when a team gets together to discuss a patient, a physician, a therapist, and a psychiatrist. There's already codes. We're unclear what these are to be used for. And CMS hasn't provided any guidance as of yet. So we are recommending excluded for now. And then when CMS issues guidance, we can either bring them back or otherwise address them. Those are the two minor issues. We have a much more detailed review of a couple of these codes. So before I kind of dive into hydrophilic urinary catheters, which I'm sure you're all just at the edge of your seat about.
Well, some of us are, yeah.
Great. Anyone want
Page
to?
140.
Does anyone want to pull out any of the other, or maybe?
Should we vote on
Do you want to vote on?
I think that probably makes
I think even the ones that are kind of pulled out with that extra stuff, they're really pretty straightforward. They just needed a little one or two, either an explanation or an additional guideline change.
Okay. So I'd entertain a motion to vote on the HCPCS codes as previously discussed before we move on to the hydrophilic catheters.
Moved.
For a second? And you, all right? Daphne?
Antoinette Awachi,
I approve.
Mary Beth Ongrave,
Approved.
Ben Hoffman,
Approve.
Adrian Irwin,
Approve.
Max Kaiser,
Approve.
Lucy Langer,
Approved.
Sarah Love,
Approved.
David Sanger.
Approve. Sorry. Approve.
No problem. Mike Collins
Approve.
and Brian Judy.
Approve.
Motion passes. Thank you.
Now we're back to page 140.
Hydrophilic urinary catheters. And so these were new HCPCS codes. And we pulled them out for a deeper discussion because our colleagues at OHA and the DME division asked us for some guidance, and also Washington Medicaid is reviewing them and asked if we wanted to kind of collaborate on a review. So when people have a neurogenic bladder, or they have a bladder that doesn't function because of nerve issues, so multiple sclerosis, spinal cord injury, or it could just be a mechanical issue like a very large prostate, these folks sometimes need to use a catheter up to 8 times a day to drain their bladder. There are people who have an indwelling catheter, either from the urethra or sometimes through the abdominal skin, that would be a constantly draining catheter, but many people do intermittent catheterization where they use these catheters just as needed to drain the bladder. The catheters come in all shapes and sizes, and they have different coatings. The ones that we're talking about today are hydrophilic catheters. They have a polymer that when it's immersed in water, it gets kind of slippery and smooth. It is marketed as less likely to cause infection because bacteria have a hard time kind of gripping onto that slick surface. But because of this coating, these catheters must be discarded after each use, although most of the intermittent catheters technically are supposed to be discarded, but patients will frequently reuse them, which is not optimal. But these catheters particularly are difficult to use after a single use. So the CMS had 3 previous HCPCS codes for any type of intermittent catheter. They were all given the same codes, and there were the 3 codes, just varied on the shape really of the type of catheter. They are now creating 3 new codes specifically for hydrophilic catheters, and then the old codes will have hydrophilic removed, and it will be for all the other types of catheters. The reason this is of concern is that a normal catheter costs about $1 to $1.50. These catheters range from $2.50 to $9 for the hydrophilic, so much more expensive. And that's initially where the concern came. And even though there may only be $1 or $2 more, typically people use 200 a month, so even a small cost becomes large. Just as a caveat to that, CMS has indicated that their general rule is that when a HCPCS code is created from a parent code, it gets the same payment. So the regular catheter code and the new hydrophilic catheter codes will have the same payment as of January 1st when it became effective. However, we anticipate that the reason they broke these out is that they will redetermine what they feel to be an appropriate reimbursement level. So just so you know, we're talking about these because of concern for cost. As of today, they don't cost any different, but we anticipate they will. So urinary catheters are DME, durable medical equipment. We don't review these typically. So normally I wouldn't have brought these to you, but we were specifically asked by our DME colleagues for advice. So the evidence, CMS did an evidence review in 2023. And their conclusion is that there is good evidence that these may reduce the incidence of urinary tract infection. But that from its systematic review, the group that they used to do their systematic review found insufficient evidence to determine coatings impact health outcomes. But there was this sort of may influence and may reduce the risk of UTIs and hematuria. So not overwhelming, even from CMS's own evidence developer. One of our highly trusted evidence review sources, Ontario Health Technology Assessment, reviewed these in 2019. They found 9 RCTs, mostly in people with neurogenic bladder, some with enlarged prostates. There were 8 studies that compared the hydrophilic directly with non-coated catheters, and 1 study that had kind of a combination of things. And essentially what they determined was that there is sort of mixed results about whether these will, the main thing would be to reduce urinary tract infections. They didn't find a difference in urinary tract infection, microscopic hematuria, or gross hematuria. They said it was low or very low quality. They did not find any difference in serious adverse events between the different types of catheters, and include those findings on preference or satisfaction among patients. So essentially they found that they were equivalent, but not better than the standard catheters. And then there was a review that was conducted for the Healthcare Infection Control Practices Advisory Committee, HCPCS. This was done in 2019. This is a group that advises the CDC. They found they did a weak recommendation supported by any quality evidence that hydrophilic catheters may be preferable. Very low quality evidence suggested a benefit of hydrophilic catheters over standard catheters in specific populations. Of note, especially the Ontario review really called out that there are only 2 studies that really showed a difference. And one of those 2 studies was done in people with bladder cancer actively undergoing the chemotherapy inside the bladder. So they are sort of a different group, and they're probably a much higher risk group because of all of the badness that happens when you have chemotherapy in your bladder. And so that was one of the reasons they also downgraded the data. They were like, the only time it's been shown to be helpful is in some very special populations. Expert guidelines, the CDC, based on that HCPCS recommendation, came up with a weak recommendation that there might be preferable, and it's sort of a long, like, it might reduce the check of urinary tract infections, which may end up reducing down the line like other long-term bad. So it gets really stretched. But the American Urologic Association also came up basically with the same thing. For adults, hydrophilic catheters may be associated with lower rates of UTI and urethral trauma. Other payers are very mixed. Most cover the new hydrophilic catheters. CMS obviously will. And I couldn't find any private payer policy, but that's caveated with before January, there was no difference. So if you were using a hydrophilic or a non-hydrophilic, it didn't matter to the insurers. And so they may develop policies, but at the time of this review, there were no published policies. So in summary, one of our trusted evidence review sources, the Ontario Health Technology Assessment, did not find any evidence that hydrophilic urinary catheters reduced infection risk. Our own CDC did say that it might be preferable, but as a weak recommendation. And they called out that those two studies in one of the bladder cancer patients were the only ones that showed any change. And CMS, however, has found sufficient evidence that these are better catheters, that they have created new billing codes. Some state Medicaid policies do have policies that they cover these. There were no private payer policies identified. Currently, as I mentioned, there is no cost difference. However, it's anticipated there will be at some point when CMS gets around to doing their whatever CMS does behind the scenes to create how much they're going to pay for these things. Based on the fact that these catheters will likely be higher cost and the evidence doesn't show that they are more effective, the recommendation is to add them to our excluded services guideline E1, which is, it works just as well, but it's more costly. And we realize that currently for Medicaid, they are not more costly, but we anticipate they will be. So any questions? Also, staff, I'm totally aware that they are equal cost now. We could open them for payment until there is a cost reconsideration and then do something. I mean, there's options here. Or we could just say, no, we're not going to pay for these. And then
However, we should note that there is a higher bar that once we do open something for coverage, to remove coverage, there's
the
a higher
evidence of
bar. There
ineffectiveness
has to
or
be evidence
harm.
of ineffectiveness, so there is a
So it would be
risk.
more difficult to walk it back.
Yeah.
Yes, exactly.
That's very helpful to know.
Yeah.
Any comments or questions?
I have a question. When CMS does establish the cost, will that will increase payment for Medicaid, or it will not?
Right, we pay a percent of Medicaid, or Medicaid pays a percent of Medicare typically.
Right.
So currently, if they're saying all catheters are $1, we pay 80 cents or whatever we pay. If they say that regular catheters are $1 and these are $5, then that would increase our cost. We would have to pay a percent.
Mary?
Hi, thanks. Great discussion and great background on this. So thank you. That was really, really a great overview. I agree with the concerns about moving forward with coverage for many reasons. One is that this is an area that's fraught with a lot of issues, which I think you're all aware, and especially in the last couple of years. And with what was pointed out with the marginal benefit, it would just really be hard to substantiate at this time. And then I guess the other thing, and maybe this is taking it one step too far, but is like you do think a lot about the global budget for healthcare. And every year there's going to be something a little better and a little different, and all these private equity companies, with these products, and something's a little different and they get a new code and the pricing goes up. And then at what point, and that's with everything, right? Not just DME, but every, imaging study, everything. And so at what point is that, not sustainable? But I agree with holding off on this.
So just a couple of comments. So with regard to the chemotherapy, just to provide a little more context, so typically if a patient has high risk non-muscle invasive bladder cancer, the standard of care therapy is to instill BCG into the bladder, and it activates the body's immune system and can kill kind of microscopic disease that's not visually seen. And if you have a traumatic catheterization, then usually with the prostate in men, then that basically allows the BCG, the Mycobacterium bovis, to get into the bloodstream. So you're at increased risk for fevers, chills, that sort of thing, or even sepsis due to that. And so it's a totally different situation, as Ariel mentioned, than the standard use. And I would say we typically would use the hydrophilic catheters, not in the setting of UTI because the data isn't really compelling. Occasionally we have some patients that are sensate, so not spinal cord injury patients, who have more discomfort associated with a non-hydrophilic catheter. And that's primarily because it's just not as easy to lubricate, whereas the hydrophilic catheter is entirely, once wet, very slippery, and that's why you can't reuse it, that coating. And so they find that they just tolerate it better. But it's not something that, like I said, we routinely use on every single patient by any means. And if you're able to, and certainly for patients that are not sensitive there.
So would you recommend doing a guideline that would let us use it for bladder cancer patients, or would you just recommend?
Yeah, I guess what I would say, so I would recommend right now, I mean, is there a possibility to be able to follow up with our urologist? Because I don't know.
I mean, we can table this and bring it back, definitely.
Okay. I mean, I can follow up with our urologic oncologist and see. I don't think they routinely use hydrophilic catheters for BCG. So, but I can follow up on that if the group felt that was really important.
There was one study that looked at that, right?
That was okay. Yeah,
we can talk more about that.
Yeah, and that one, that was the only one that found, or one of only two that found a reduction in.
Right, so if we're talking about the whole subject, we just take it out.
Yeah.
Mary?
Sorry, that was my hand from before.
If we're going to put it aside and ask for more information, I think it would be useful to check with the Spina Bifida clinic folks, because I do worry about the cumulative impact of lifelong catheterization, which we see with kids with Spina Bifida. And if there's only 3 studies that were included in urogenic bladder, I want to get a sense of what the perceived standard of care is now, even in the absence of adequate evidence.
Yeah, I get, we could do that. So the context for that is just that lifelong catheterization, increased trauma, getting, theoretically, I don't know the data, but the concern is for squamous cell carcinoma of the bladder. It's a different type of bladder cancer that develops in the setting of prolonged inflammation to the bladder, either from indwelling catheters or repeated catheterizations or UTIs. So,
and also the impact on renal function.
Yeah, and the evidence didn't show.
With repeated pyelonephritis.
Yeah, the evidence didn't show that the hydrophilic catheters resulted in less trauma. So, catheterization is traumatic.
Period.
So.
Okay, so then I guess, so then I would entertain a motion to table this or we don't have to. Okay, well, I guess we're going to table this until, and we'll look into more information with regard to specifically intravesical chemotherapy and immunotherapy for bladder cancer, and then we'll get back to the group in the March meeting.
Yeah, so what we would probably have a couple options then in March. We'd probably have put it on one saying, no, we're never going to cover it, or do an ancillary guideline saying we only cover these for people undergoing intravesical BCG, and if there's any other group, if the evidence has I can look at the 2 studies that really show that benefit and just see if I can piece out maybe so that those, we would come back with some options. Does that sound agreeable? And then I will reach out to you, Brian.
Yeah, I'll talk to our urologic oncologist and about that and see what our standard practice is, and we can ask some other institutions as well.
Yeah, and I don't think there's a rush because currently right now they're the same cost.
Correct.
So,
Yeah, exactly. All right, is that it for this block then?
yes.
Okay.
Any other things that anyone wants me to look into before I bring this topic back? Okay.
Okay.
Yeah, we don't need a break.
Yes.
The break is at 10 because when we were starting at 8, I thought we'd need one.
Okay.
Are you all okay diving in a little bit?
All right, so we're gonna move on to the new discussion items.
Yeah. So the first one is laboratory tests with minimal impact on health.
Page 146.
Thank you. So this, you'll all recall we had some in-depth discussions about viral respiratory panels in the fall. And that kind of piqued staff interest to see, are there other labs, other things that we would typically just cover because they seem to be a diagnostic test that perhaps we should look at that are not really having much impact on health. And we found several that we want to discuss removing from coverage. And they have a wide range. Many of them aren't being used, which is appropriate because there aren't really labs that are useful. And then there are other ones that are just odd. So the first one is CPT 80050. It's a general health panel. This includes a metabolic panel, a blood count, and a TSH. Those are all very common labs that are done in the primary care setting. And they each have an individual code. It turns out that the panel code is like $20 more than the individual codes, which I had a good explanation from the folks about why that is. It's something with CMS. CMS stopped updating this because they don't cover it. So they haven't updated the amount. So we haven't changed the amount we're paying. The other concern is that a metabolic panel and a CBC are very common. TSHs are frequently overdone. They probably don't need to be drawn every year. Every few years is fine, or when there's symptoms that would be, you'd want to do something. So the recommendation is to stop covering the general health panel, which would actually conform with what CMS is doing. We would continue to cover the 3 individual tests that compose it and save ourselves some money. And what we're thinking too, one of the reasons this had so much cost associated with it is that it had like $2 million of cost. The labs may be bundling them because they get paid more than if like I order the 3 separate labs, they may actually bill for the combo, even though the 3 separate labs were the codes that were ordered. Then there's infectious agent quantification labs. So this isn't to see if it's there, yes, no, it's to see how much is there. That's really important in certain diseases like HIV, a viral load, or perhaps Hep C. You want to know, does somebody have a high or a low viral load? There are a lot of other tests where you don't really care how much is there. It's more of a yes, no. So these would be things like Candida, chlamydia, Gardnerella, gonorrhea. These are all common diseases we really would treat if there was any there. We don't care how much is there. None of these actually are being used. So the recommendation is that we move them over to the excluded services guideline because they aren't useful and they're not being used. Then there's a set that are 3 laboratory tests that actually had a lot of billing. And these are 87797 to 87799. These are infectious agent detection using DNA or RNA, each organism. These are used for all kinds of things. So it would be if you had a wound infection or bladder infection, it would be looking for the DNA or the RNA of E. coli or gonorrhea or whatever, rather than doing the typical culture. Many of these are not covered, or they're explicitly only covered for something like Zika virus testing, that is designated by one of them. And it's because of concerns. So if I am doing a vaginitis panel, which is a woman comes in with vaginal itching and pain, we can do a panel and they kind of look to see if there's anything there. There's a whole bunch of codes for that. You could use this code instead, and it actually bills it bills each time there is a organism. So rather than billing once for a panel where it gives you a list of organisms, it bills itself like 10 times and then reports 10 organisms. So it's kind of a quirk of the lab. And many of these are, or all of them, we have other lab tests for that are frequently concerned. I discuss these with our CCO medical directors. We have a meeting once a month. And they reported seeing high use of these for UTI detection, which is not a cost-effective way to determine if somebody has a UTI. And so the recommendation is to exclude these 3 codes that would be consistent with Medicare and private payers and would remove this sort of strange thing where they can bill multiple times for the same test. It's labs, they want to stay in business.
Ariel,
Yes.
this is Mike. So I'm looking at that $2.4 million on 87798. So we're looking at like what, 100,000, what is that, 100,000 tests? Or 100,000 hits, I guess.
Right. So it's 100,000 times that code has come across, but it might have come across 10 times for the same patient for the same sample.
Understood.
So we don't know how many patients. The things that they are testing for can be tested with other already available open tests. So we don't think it would impede the ability of the clinician from looking for vaginal infection, looking for UTIs. It would just direct people to more appropriate testing. And so it looks like you would save 2.5 million. You probably aren't. You're probably going to save less than that because there'll be other appropriately coded tests being used. Does that answer your question?
Yeah, thank you.
And obviously we had some outbreak of a new novel disease and CMS told us to use this code to test for a new agent, we would reopen it or whatever we would need to do. And then there's a series of infectious disease labs that Medicare doesn't cover. These were all, it's where an agent is cultured. So they put it on an agar plate, they grow it, and then they use DNA to figure out what that is rather than sort of the standard old-fashioned, whatever they do at infectious disease labs to determine this. These codes were really not being used except for a Staph aureus code, and there are other testings that are available. The other problem is when Medicare stops covering something like we saw with that comprehensive medical panel, we stop updating how much we're paying because Medicare doesn't send us updated amounts to pay. And then there's COVID antibody testing. These were widely opened appropriately with the COVID epidemic. And now there are some things that are not to be used. So COVID antibodies were initially used in the beginning of the epidemic. If somebody had COVID antibodies, it would determine some of the treatment pathways. Now in the United States, over 99% of us all have COVID antibodies, either from vaccination or from disease. The CDC doesn't recommend checking that at all anymore. These aren't being billed and we don't think we should be covering them. So what this whole package would end up being would be excluded services E1, which again is the, these tests work, but they're not the most cost effective, or there's other equally effective tests. And so they would all be listed in there. And this change would be effective February 1st because we would want, we don't think these will have an impact on clinical care or health, and we think they will save the agency money. Any questions, concerns?
Just Mary, no questions. This has been like, I know, really on the radar kind of across the board in our world. So really appreciate the background and work on this. I think this is really ahead of the curve, which I think a lot of folks aren't. So great job on this.
Thank you. And if anyone sees other things come across their desk that they're concerned about how that lab, let me know. The next one kind of is along the same lines of things that are high cost and not terribly helpful, or these are helpful, but they were extremely high cost. So skin substitutes.
Page 154.
These are engineered artificial skin that's used for wound care generally, could be used for burn care, skin ulcers, etc. This has become an area of major waste, fraud, and abuse. Medicare spent $10 billion on this in 2024. And they found crazy overbilling, overuse. I think there was millions of dollars on a single patient somewhere who doesn't report ever getting it. These are just huge, huge problems. So Medicare has done a big crackdown. One of the major things they did was that they set a single price for all products. That was effective January 1st, and the agencies already implemented that. And so some of these were wildly crazy expensive, and so now they'll all be a set price. They also updated the Medicare guidelines about when these can be used. We do have a similar guideline on the prioritized list. In your packet, you can see the Noridian, which is the Medicare contractor for the Pacific Northwest, and all of their changes. So staff recommends aligning with the new Medicare coverage. So there's a single payment for every product that's already been implemented by our billing folks. And then more clearly requiring standard wound care. And so kind of really listing out, infection control, debridement if necessary, offloading, smoking cessation counseling, that type of thing. We had an A1C and an ABI level. So for diabetic ulcers and ulcers because of inadequate blood flow, they've changed it to adequate disease management because that probably just better aligns with care. And then the other major thing they did is they put a maximum number of applications as 4, with an additional 4 if the patient's progressing but needs more. So basically only 8 within a 16-week episode. That's also addressing a major waste, fraud, and abuse that Medicare was seeing. So there's wording to go along with that. So we'll mirror Medicare, limiting applications to 4 with an additional 4 with a provider attestation. And then we had discontinuation and also adding, so if you've gotten your 4 approved and it's been unsuccessful, you have an increasing ulcer size or depth, no progress toward closure, that type of thing, then it would kind of automatically be done. You can't get the next 4, although the provider could always, do a individualized, this is what's going on with this patient. And then you can't use these if the wound bed is infected, ischemic, etc., because it's not going to be helpful. And so there's a lot of word changes if you look at the guideline, but those are sort of the effective things. So we're taking out the ABI for adequate blood flow. We're taking out your diabetes, and we're asking that you have appropriate care. And then we're documenting that you have to provide documentation, and this is now Medicare policy, so providers should be familiar with what they need to document that they need. We are looking at, we've already offloaded the person, we've we've done a debridement if that's indicated, et cetera. There's a maximum number of 8 with 4, and then an attestation after 4 that the wound is continuing, that they're continuing to do best wound care practices. And we won't approve the additional 4 if there's no change. And then there's no coverage if you have infection, have ischemic necrotic wound beds, etc. Any questions or concerns? The wording is pretty much taken directly from the Noridian guideline. Hearing none. On to nasal polyps.
Page 162.
So nasal polyps are growths in the nose. They are typically from things like allergies, but they can cause obstruction of a sinus opening, bleeding, etc. There are also benign tumors that can grow in the nasopharyngeal cavity. And the polyps and the tumors are currently on an unfunded line. But our guideline note about chronic sinusitis says that we, for sinus surgery, says that you can do like a nasal polypectomy if it's causing sinusitis, but we don't cover the sinusitis, so it's very confusing to reviewers. And so in our current guideline, sinus surgery is indicated if you have nasal polyposis causing or contributing to sinusitis, but you can't actually code for the polypectomy that would be needed to accomplish that. So expert guidelines, the American Academy of Otolaryngology Head and Neck Surgery has a guideline from 2025, and they talk about to assess candidacy for sinus surgery, you use something, I love them, the SNOT 22 for quality of life, and then there's radiographic, etc. And then they recommend surgery for chronic rhinosinusitis with polyps with bony erosion, etc. The major insurers, Aetna, Cigna, Blue Cross Blue Shield, generally agree with our current prioritized list guidelines that nasal or sinus polyps causing obstructions and benign tumors are covered indications. So in summary, expert guidelines do recommend nasal polypectomy if it's contributing to chronic sinusitis. And the current guideline is consistent with that. But these are non-covered diagnoses and procedures, so that's sort of internally in conflict. The nasal polyp diagnosis and procedures were added to the sinus code grouping for 2027 for the BUP list. We recommend, actually this would be our 2-1 list, not our 1-1 list, wording changes that would be included on, so doing the BUP changes early. And then also adding the benign nasal neoplasms and only covering that when it would cause chronic sinusitis. I realize that there are rare cases where there's a benign tumor that's causing major destruction, et cetera. That would be an easy exception, hopefully, where you, even if it's not a cancer, if it's growing and causing local destruction, that would be a different topic. So what the recommendations are is to add nasal and sinus polyp ICD-10 codes to the chronic sinusitis line. And I'm sorry, the materials say effective 1-1. These would actually be effective 2-1. And then the benign neoplasm of middle ear, nasal cavity, and sinuses would also be added to the chronic sinusitis line.
Wait, will we do, I thought we were just doing the labs. 2-1.
Okay, this would be 10-1 then?
10-1.
Okay. Okay, this would be 10-1. And then we would modify our guideline and we would have a note in the guideline. Nasal polyp excision and other treatments for nasal polyps are only included when done to address chronic sinusitis. Otherwise, nasal polyp excisions and treatments are included on the non-funded line or would be not medically necessary in the BUP world. Treatment of benign neoplasms of the nasal cavity and sinuses are only included on the sinusitis line when causing chronic sinusitis or other complications. Otherwise, they wouldn't be medically necessary on the unfunded line. Questions, concerns? And my apologies for the confusion. This would be implemented 10/1.
Even this one for this is effective 1/1/2027. Is that 10/1/26 or 1/1/27?
That would be 1/1/27. That's the BUP.
Okay.
There's the.
Gotcha.
It would mirror. It would be our updated guideline, but mirroring the. We have to have different words. Same meaning, different words. Great. Dorsal rhizotomy.
Page 170.
So dorsal rhizotomy is a procedure where you go in and cut a whole series of nerves that are motor nerves to muscles. You do that when someone has a condition like cerebral palsy where there's too much muscle tone and it causes muscle contractions. And we currently cover it only to help someone gain the ability to walk. And so many people with cerebral palsy and similar conditions can't walk because of their tone is too high. And this would help them. The question came to us from a case that came to medical management committee of a patient that will never have the ability to walk, but their the contractures of the muscles were really making caregiving and perineal bathing, et cetera, really difficult and causing pain. And the request was whether we should expand our current coverage. So there's a systematic review from 2013 looking at this selective dorsal rhizotomy. And they did really comment on ability to walk, sit, or stand, but they also had other goals, including contractures and reduction of pain, improving caregiving, sitting balance, and improving transfers. Our Health Quality Ontario, our highly trusted evidence source, did a health technology assessment in 2017. They did find that if you did dorsal rhizotomy, all the studies reported clinically important improvements in functional independence with self-care and mobility. They also what the studies that did evaluate caregiver assistance reported less dependence on caregivers. Expert guidelines. There's a global package of interventions for people with cerebral palsy. It was published in 2021, and they basically said you can do dorsal rhizotomy, but you need to do everything else that's less. I mean, this is not a fun or pleasant or good. I mean, it is good, but it's not something you just want to try. You would need to have tried everything else first. And other payers all cover for some flavor of this type of thing. I mean, and California Medicaid has some specific policy wording around it. So in summary, our current guideline restricts it, dorsal rhizotomy, to patients who are able to ambulate, and it also had some age restrictions that aren't really consistent with the literature. There are other things that are probably would be justifiable, and realizing this is kind of a last ditch intervention rather than an early intervention. So the guideline note would change to say, if you're doing the surgery to improve ambulation, we are keeping our age restriction 2 to 10 years, and that's because of the ability to gain function and sort of neuroplasticity, and that is consistent with other policies and evidence. And then if it's a palliative surgery for a non-ambulatory child, it's under the age of 21, and you have to have a significant limitation in function and mobility or gait, and you have to have no contraindications and do any ability to do any possible rehab after. Questions or concerns? And Ben, being a child-centered topic, you're comfortable with it.
Is the rehab part restrictive for the palliative approach? Like that case that came to the medical committee, was that individual able to participate in post-op rehab? I can
Depends on
imagine.
what you would, I mean, if it's rehab for like improving range of motion of a joint, probably.
Oh, sending it passively? Okay.
Yeah.
I'm just thinking if you're doing it for palliative, there's gotta be cases where they can't participate meaningfully in post-op rehab.
We could put that D has functional capacity and motivation to participate in rehab, and we could put it under the improved ambulation.
Yeah, I think it's appropriate there. Yeah, I'm not sure it's appropriate for I don't know, this is a question. I'm just imagining scenarios, and it seems like there would be a lot of cases that wouldn't be able to meet that would be appropriate for the palliative approach. I'm kind of speaking theoretically, not.
Yeah, and it was
From
in there
experience.
with our previous just for walking. So I think it would be reasonable to make it, so you have the, if it's to improve ambulation, you have to be between 2 and 10, blah, blah, blah. And then it would say you have to be able to participate in rehab.
Yeah, I think that's what the other piece, right?
So there would be a little D instead of our big D. And then you have to have tried and failed other things.
Yeah, the other parts make sense. Yeah.
And that, the big E is left, just a little, just the big T is because it's under that.
Yeah, and leave the big F. Well, I guess now it becomes big E.
Yeah. Yeah, I think that's consistent with what we actually are intending.
Yeah.
Our next topic is nutrition counseling for pre-diabetes.
Page 181.
And I know we had a person who wanted to provide verbal testimony. Is that person online and present? And are they ready and willing at this? Is this a good time, essentially? Okay, so a thumbs up. Okay, so this is a medical nutrition therapy for pre-diabetes. This came to us from denied claims review. So there were many claims for dietitian services for people with pre-diabetes. So as a reminder to you all, pre-diabetes is a condition where the average blood sugar is above the normal range, but it's not in the diabetic range. And this is a sort of a mishmash. There's probably some people who have slightly elevated blood sugars, and that's normal for them. Some people who could just do some very easy lifestyle changes and address it. And there are other people who are probably going to develop diabetes unless they make some major changes to diet, exercise, and other lifestyle things. The pre-diabetes does have, in that group that might go on to diabetes, that the American Diabetes Association reports a 5-year risk of about 50%. So half of people who are told they have pre-diabetes may develop diabetes within 5 years. The other half don't and may never. So this is, I think, one area where a lot of patients and providers get a little frustrated because you're not quite sure what to do. There is a highly evidence-based program called the Diabetes Prevention Program that's been shown to reduce the risk of diabetes if you have pre-diabetes.
The internet just failed, where it looks like we've been kicked out.
Oh, I see you. I see you and hear you.
Oh, okay. I'm sorry.
I just don't see the agenda or the meeting packet.
I think Liz's computer specifically got kicked out. So there's a TBD slide. So there were multiple denied claims for medical nutrition counseling when we looked in 2024. Medical nutrition therapies is on 38 lines for diabetes, renal disease, various GI conditions, heart disease, inborn errors of metabolism, eating disorders, epilepsy for the ketogenic diet, etc. There are many indications where dietitians can be extremely helpful. We reviewed prediabetes most substantially last in 2018. And that was essentially looking at the diabetes prevention program, which is strongly evidence-based. CDC has really heavily promoted it. And we added a new guideline to the prioritized list about the diabetes prevention program. So prediabetes is on our line 3, preventive services with evidence of effectiveness. And that is mainly for use with the diabetes prevention program. And then we also.
Would it be helpful if I shared in the interim, since it's not being shared, or does anybody not need it?
Is that possible, Daphne, for a non, like host or something to share?
I can do it.
Okay.
I'm a host. Let me find it.
You're a panelist, just like Liz was. You should be able to share.
Yeah, I have the share button as well.
Okay.
I'll have it up in just a second.
Okay. So looking at the evidence, there was a systematic review published in 2023, specifically looking at lower intensive interventions. So the diabetes prevention program is considered a high intensity intervention because it's a very intensive program. So these are less intensive interventions. And lower intensity was defined as having a duration of less than 12 months with less than 14 sessions over 6 months. And they had to have a comparison group of either usual care or minimal intervention, which is usually either standard medical advice or a handout. And they found 11 RCTs, 7 were considered low quality. 1 trial with low risk of bias, 8 trials with moderate risk, and 2 trials with high risk of bias.
Sorry, page 184 for those of you online.
And the 9 studies reported on body weight outcomes, and 3 reported it. So the majority did not report a statistically significant reduction. For BMI, only 2 of 9 reported a significant reduction. Hemoglobin A1C changes, 9 studies reported on it, and only 2 showed a significant change. Similar 11 with fasting glucose, and only 2 showing a significant change. None found any favorable change in physical activity. So their conclusion was that few studies found that lower intensity interventions were effective and for pretty much any outcome. And the author's conclusion was that we really should be focusing on the higher intensity interventions like the DPP. Similarly, there was a systematic review done in 2023, and it was looking at specifically medical nutrition therapy provided by a dietitian. So many of the less intensive programs may have been provided by a community health worker, a nurse, medical, a physician. Didn't say that it had to be done by a dietitian. So this was one that looked only at studies that had dietitians. And they looked at only at controlled trials. They found 13 studies, and they, based on only 2 of those, there was a low certainty evidence that nutrition therapy provided by a dietitian or the international equivalents reduces incidence of type 2 diabetes. And then there was low certainty evidence based on 7 studies that there is a reduction in A1C with a reduction of 0.3%. And as a reminder, HERC has traditionally used 0.5% as being a significant reduction in A1C. And then the USPSTF did a review in 2021. They found 38 RCTs of patients with screen detected prediabetes. 18 of those were intensive, and 5 were medium intensive, and 2 were low dose interventions. The meta-analysis of 23 trials found that lifestyle interventions were associated with a reduction in progression to diabetes, and they said that 9 people with prediabetes would need to be treated to prevent 1 case of diabetes over 15 years. But these, they basically thought that these were mainly due to the high contact interventions and not to the ones that were more low intensity interventions. Expert guidelines, the American Diabetes Association, their standards of care from 2024, they recommend referring adults who are overweight or obese at high risk of type 2 diabetes to the diabetes prevention program or an intensive lifestyle change program with a goal of weight reduction of 7% of body weight. And then they did recommend individualized medical nutrition therapy to lower A1C in patients diagnosed with prediabetes. It was a statement, not a recommendation. And it was based on one RCT from 2014. Most private insurers do not cover medical nutrition therapy for prediabetes specifically, outside of the diabetes prevention program or other intensive interventions. So in summary, the high quality ARC review found good evidence to support intensive intervention, such as the diabetes prevention program. Recent systematic reviews have looked at prediabetes with less intensive treatments. They did not find consistent evidence that that any treatment or medical nutrition therapy done by a nutritionist resulted in lower rates of diabetes, although the medical nutritionist delivered services may reduce A1C by what we would consider a non-significant amount, or not clinically significant amount. Private payers, Medicare and Washington Medicaid are not covering medical nutrition therapy for prediabetes. Of note, the ADA in their guidelines states that it can be done, but it's not an official recommendation in their guideline. At this point, HERT staff don't recommend adding medical nutrition therapy for prediabetes outside of the diabetes prevention program or other high intensity similar program. Any questions about that before we hear our testimony? Daphne, can you?
Daphne Nance.
Yeah, I'm getting to it. Hang on. This topic may be a sensitive discussion for some, and as a reminder, HERC is a policy-making body and can't make decisions about coverage or care for individuals. Any policy changes resulting from today's discussion will go into effect at a future date. This discussion may be intensely personal for some, yet in this forum, we tend to discuss subjects in terms that can seem clinical and impersonal. Not everyone's experience will fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using HERC's methodology and processes to determine the importance of services. Today, we're allowing 3 minutes a person to testify. We have one person to testify. Please note a progress bar will show how much time is remaining. And after your allotted time ends, please remain in the meeting for a few moments in case members have questions for you. I will momentarily press the button that will allow you to speak. Please begin your testimony by stating your name and any potential conflicts of interest you have regarding this topic. And I'm introducing Matt Prokop. Please tell me how to pronounce your last name. I would appreciate it. Thank you, Matt.
Can you guys hear me okay?
Yes.
And you're correct in terms of pronouncing my last name, so thank you for that. Thank you for the opportunity to provide public comments today. My name is Matt Prokop, and I am the Director of State Government Affairs for the Northwest and North Central region for the American Diabetes Association. We appreciate the state's continued support of the National Diabetes Prevention Program and ask for your consideration to add coverage of medical nutrition therapy for those living with prediabetes. The American Diabetes Association Standards of Care this year emphasize that building positive health behaviors and maintaining psychological well-being are foundational for achieving diabetes management goals and maximizing quality of life. Essential to achieving these goals are diabetes self-management education and support, medical nutrition therapy, routine physical activity, adequate quality sleep, support for cessation of tobacco products and vaping, health behavior counseling, and psychosocial care. Access to the National Diabetes Program is essential and effective in preventing the progression of prediabetes and obesity to type 2 diabetes. Our standards of care also state that an individual medical nutrition therapy program, as needed to achieve treatment goals and be provided by a registered dietitian nutritionist, preferably one who has comprehensive knowledge and experience in diabetes care, and is recommended for all people with type 1 or type 2 diabetes, prediabetes, and gestational diabetes. Services provided by the National Diabetes Prevention Program and medical nutrition therapy programs complement one another by providing evidence-based support through group or individualized lifestyle modification programs that lead to better health outcomes and cost-effective care. One example of cost savings from access to medical nutrition therapy was featured in an October 2025 article from the Journal of the Academy of Nutrition and Dietetics. Data from the article indicated that access to medical nutrition therapy can lead to cost savings of $638 to $1,450 per patient per year due to reductions in use of medications. Latest data on obesity rates in Oregon from the American Diabetes Association also show the need for providing comprehensive treatment options for obesity and prediabetes. Obesity impacts 1.4 million adults in Oregon, with rates projected to increase from the current rate of 34% to 47.5% by 2030. Preventing type 2 diabetes and the 200 chronic conditions related to obesity require a multifaceted approach in providing coverage for effective evidence-based treatment options. We strongly recommend that the Oregon Health Evidence Review Commission continue coverage for the National Diabetes Prevention Program and add coverage of medical nutrition therapy for those living with prediabetes and diabetes. Thank you for your time today.
Thank you for your testimony. Any questions for Mr. Prokop? All right. Thank you very much. Once again, we appreciate your time and comment.
We need discussion about this topic.
Just to be clear, obesity would still be covered?
Obesity and diabetes, type 1, type 2, and gestational.
That's sort of a dumb question. Just wanted to be very clear about that.
Yeah. Other questions or comments? Okay.
Yeah, and medical nutrition therapy is covered for a whole host of variety of medical conditions affecting various organs. Are we ready to move on? Our next topic is epithelium on corneal cross-linking for keratoconus. This is a kind of a
Page 176.
a very highly specialized topic. Keratoconus is a condition that damages the cornea, the outside of the eye, which can lead to vision impairment and can become quite severe. And it commonly affects children and young adults and can be progressive. So there's various things you can do with contact lenses, etc. There was an advancement a few years ago where they developed corneal collagen cross-linking using riboflavin, and it was done about 20 years ago. And this requires you to take the epithelium off the eye, so it's epithelial off corneal cross-linking. They take the ophthalmologist does a small incision, removes the outer layer, puts this medication on, and it's been shown to be quite effective at reducing disease progression and need for corneal transplant. There's been and we adopted coverage for the corneal off in 2022. A new product just received FDA approval for epithelial on. So there's, you don't remove the outer layer of the eye, you apply the medication, and then there's special goggles that are used that sort of drive the medication through the ocular surface. It's marketed as reducing patient discomfort and recovery time. Of note, the manufacturer of the product for epithelial off is the only manufacturer for the product for epithelial off. And they have announced they're no longer going to be covering the epithelial off cross-linking since they've gotten approval for the on cross-linking. So we currently have a guideline note about corneal collagen cross-linking that we adopted several years ago with the help of our ophthalmology colleagues. So the evidence on this consists of a systematic review that was published in 2025 of 13 RCTs with about 1,000 eyes. And they had epithelial on or epithelial off. So these were kind of comparing the two procedures, and they found that they seemed to work just as well. The epithelial off cross-linking resulted in more complications such as delayed healing and corneal scarring. And the epithelial on had fewer adverse events, less pain, and less other complications. So essentially their conclusions were the two types work just as well. The epithelial on appears to have fewer adverse events. There was a technology assessment done by our Center for Evidence-Based Policy colleagues for the state of New York, I believe. It was published in 2024. They included 10 RCTs and there were 6 of those compared the epithelial off to epithelial on, and noted same thing. They work as well. Epithelial off had more serious adverse events. Other payer policies generally consider epithelial on to, if they specify, they typically specify they don't cover the epithelial on. It's not medically necessary. Other policies don't say, they just cover corneal collagen cross-linking without any specification if it's on or off. The VA in 2025 specifically came out and said that epithelial on cross-linking is experimental. And then there were some definitions of progressive keratoconus. I pulled these out specifically because of some input from one of our ophthalmology colleagues about needing to define what we meant by progressive keratoconus. And it's various technical, wonky, certain increasing measurements of keratotomies. So I pulled those out for you. I conferred with an OHSU ophthalmologist, Dr. Richard Stutzman. He recommended covering the collagen cross-linking with no additional limitations, and he wanted to define what we meant by progressive keratoconus. So in summary, the epithelial on cross-linking is it's effective, and it's as effective as corneal off and may be slightly safer. Private payers mostly consider it to be experimental, but based on the high quality systematic review and expert input, the staff recommendation is to add coverage for epithelial on, with also the note that there appears to be a cessation of the ability to cover epithelial off coming shortly. And then also based on our expert input to add a definition for what we mean by progressive keratoconus. So what we will do with our current guideline note, they use the same CPT code for both epithelial on and epithelial off. We will remove conventional epithelial off words from the guideline. And then the progressive keratoconus has this wonky, what the ophthalmologist felt was very appropriate based on ophthalmology words. Sorry, ophthalmology is Greek to me when you read their things.
It is.
Yeah. I think it's Latin.
Actually, I believe you might be right. I think it's, you still use sinister, like OS.
Yes.
Yeah.
Yeah, I can't get it's called right.
Any questions?
We don't have a way of controlling payment, right? We have no function there. I think this is all erroneous. It doesn't matter because one's going away. There's only going to be one existing, right? Right. When it's off, it's not
What
even an option.
mechanisms would we have?
I don't know. I'm just trying to think it through because if we were actually talking about data, I would have significant questions. The side effects of it are pretty rare, and the on is more expensive than the off.
It's
right?
significantly more expensive, and
Right.
the adverse events are generally minor, so a little bit of pain.
Right.
And it takes 3 days to heal versus 1 day to heal.
Which is why I'd have serious questions covering it, but it doesn't sound like it's an option because it's a medically necessary procedure that the other one's going away.
Correct. I think personally, based on the evidence, it's equally effective, but much higher cost. We might have considered E1.
Right.
But I
That's why I'm having
feel
a
like,
conversation.
right. I feel like we would be doing a disservice to patients if we didn't cover it, if they truly are gonna.
Right, that's why I'm thinking, is there any, and I don't know, but things with like, CMS did this, but with the skin substitutes, we said, hey, we're just gonna pay all the same price no matter what it is, because it's not really any better.
That's DME, this is a drug.
Right, I know, I'm just, as an example, I don't think we have a mechanism, so I'm saying it out loud to talk about it. Is there something I don't know? Side issue, that guideline, that's gonna be really hard to implement, because as you have read ophthalmology documentation, they often have words and ways of phrasing things that they know. Often our reviewers don't. And I have to spend a lot of time kind of translating. And even when we've done that with what we are told ophthalmologists how they document, they still don't include that information. So
yeah,
no idea with these, haven't seen one of these. Then that's gonna be tough. Total side issue.
And if you do find that it's difficult to implement, please let us know. I did take that wording from 2 private payer guidelines and ran it by the ophthalmologist. So
we have trouble with the CMS one for blepharoplasty and lymphedema. At least our ophthalmologists have asked for it, don't document in a way that CMS says they should. So, side issue. As you said, they use all different words, it takes a lot of translation, side issue. Yeah, I don't know if there's a.
I don't know, what is a manifest cylinder?
I literally looked up for the blepharoplasty, I literally looked it up and wrote down the things to figure out what it was. And I had to like read ophthalmology articles to figure out, oh, it's the difference between their lid and the center of their pupil. Does anybody measure that? Apparently. Okay, anyway, side issue. That's gonna be hard to implement.
Okay.
I don't know a way around it.
And from
The
what
cost
I
part of
have
it is
been
more an issue.
told by our ophthalmologist, this is a rare, it's very rare that they do this.
Okay.
I
mean, it's more a conceptual point than functionally how much of a problem is it going to be. So I think it's worth having a conversation. I don't think we have a mechanism. There's mechanisms outside of our group.
And talking to our colleagues at Pharmacy and Therapeutics, PMT, they have to cover the drug. And if we don't cover the procedure to apply the drug, that also becomes a problem.
I think we have to cover it. I'm trying to think of a way that we don't spend a bunch of money because a company decided to sell us a more expensive thing that's not any better. Right?
It's
so,
like 16 times.
So like coverage, totally fine with a guy that knows all that makes sense. That's not a system I like. So if anything, we should maybe give feedback to higher levels that like, hey, there should be a mechanism for this.
I mean, you could write to your representative.
Right, I know. Those are the other ways.
You could go to Washington, D.C. It would be the most
We have
appropriate way
seen a
to
lot of
address
feedback on a lot of other issues that are much larger, more common, and those haven't gotten traction. That's not gonna happen. I totally do that. Right, there's other mechanisms, but it makes sense to have a mechanism in this group, or at least feedback to a group that does budgetary decisions to say like, hey, this is not a good use of our state money, right? So by technicality, we can't control this. That doesn't mean that's a good system, right? So if we can give that feedback, like we ran into this
are
thing.
all noted.
Right, okay, perfect. Great. Thank you.
Okay, all right.
Manifest clarity.
So we're gonna manifest occupational therapy now.
Oh, by the way,
I guess
it's
there's
great. You were right, it was great.
Yeah.
Not left.
Might as well be Martian.
I see Mary Beth's hand raised.
Oh, okay, thanks, Daphne.
Sure.
Oh, hi. No, I completely agree with what Max is saying. And I'm just I'm thinking out loud here as Max is doing, but I've spent so much time on these cases trying to sort these out in the past. And the comment that it's almost impossible is right. I guess if there's any rotation I could redo from residency, it would be ophthalmology, just to remember like what the heck half the stuff means in the notes. But it's so hard to sort out. And then
Would you just get rid of the guideline and just
I don't-
cover it?
Okay, here's my dumb question of the day, and I'm ashamed to ask this question. Is this something where there's any risk of overutilization? Like, you know what I'm saying? Like, there's always theoretically, but is there any time they ever use this for like refractive changes or like it's advertised? Like, if there's no risk of it, it seems like maybe we just like, is it worthwhile reviewing these if we're truly saying 99.9% of these are Med-Ness or 100%, and there's little to no risk of this, but I'm not smart enough to know the answer to that.
I mean, my guess would be yes, if the ophthalmologist asked us to define that, that says that they have certain criteria and it could be used in different ways. I think at the state level, it makes sense to put in guidance for individual CCOs. I think it makes a heck of a lot of sense to go back review. If the demand is not that high, we can always cover more, we can't cover less. So we can take that off review as an individual CCO based on our communities. I think, yeah, I would agree. I think this is probably not going to be an issue, but we kind of have to go with what is the evidence base at the policy level.
So you're saying we have a basic guideline, we have something to stand on if they're using it for someone with mild keratoconus that's not progressing. But otherwise, if you're not seeing many cases, you might just not PA it, and it might just go through.
Yep.
And that would be appropriate
Yep.
for your CCO, if that's your decision.
All right, we are live.
Welcome back, everyone. We're continuing with our VbBS meeting. Our next topic is occupational therapy for ADHD.
Page 189.
Thank you. This came to us from Betsy Gaffney, who spoke at one of our staff listening sessions. And she advocated for adding occupational therapy for adults with attention deficit hyperactivity disorder, ADHD, based on she is an occupational therapist, and based on her, what she sees as the positive benefits for the clients that she sees. ADHD is a common neurobehavioral disorder. It can cause lots of issues with academic achievement, well-being, and social interaction. And it has various treatments, including behavioral psychotherapy, as well as medications, the Ritalin, Adderall, that kind of family of medications. ADHD is on line 121, and occupational therapy is on over 60 lines, but not on line 121. So looking at the evidence supporting the treatment of ADHD, AHRQ published a systematic review in 2024. They looked at cognitive training, and they found 22 studies, and cognitive training had no statistically significant effect on problem behavior. Oh, just by the way, occupational therapy could be considered a type of cognitive training. That's why I pulled cognitive training out. So for problem behavior, they set a low strength of evidence for no effect. They did find a statistically significant improvement in broadband measures. These are sort of global scales for academic, behavioral, emotional, and social domains. It was a low strength of evidence for benefit. They found no improvement of ADHD symptoms with cognitive training compared to control groups. But removing high-risk studies indicated a lack of systematic effect. They didn't find a significant impact on functional impairment. And they found that the treatments that did have higher moderate strength of evidence were FDA-approved medications and psychosocial interventions, specifically cognitive behavioral therapy. And of note, that already is on the ADHD line. There was a series of submitted articles, mostly on diagnosis and other pieces for ADHD. Expert guidelines. There was a guideline published in 2019 on the diagnosis, evaluation, and treatment of ADHD. It did not mention occupational therapy. It did recommend training and behavioral treatments which target skill development and involve repeated practice with performance feedback over time, and recommended medications. I only found 2 payer policies that addressed OT for ADHD. Aetna does not cover it. Cigna covers occupational therapy for cognitive and psychological diagnoses, but didn't list ADHD as a specific diagnosis they cover. So in summary, the evidence base for occupational therapy for ADHD, it's most robust in children and adolescents. Very little has been studied in adults. A recent ARC systematic review found low strength of evidence that OT interventions improve broadband measures, but not problem behavioral or functional impairments. And OT interventions may improve ADHD symptoms. The American Academy of Pediatrics does not include OT interventions in their treatment recommendations. There were no guidelines found for treatment of adult ADHD, and it's not clear if private payers are paying for OT for treatment of ADHD. But based on the limited evidence of effectiveness of OT as a treatment for ADHD, HERC staff does not recommend adding OT procedure codes to the ADHD line. Seeing nods in the room, anyone have questions or concerns?
I see Dr. Sanger's hand up.
Thanks. Do we cover pharmacotherapy for ADHD? I mean, it seems like OT is a lot less likely to have side effects and drawbacks than pharmacologic therapy. I mean, it's and it might even be lower cost. I would be, and also, could we separate out the pediatric from the adult ADHD? Because I think that those are different. Sorry, those are my thoughts.
I pulled the adult or the children and adolescent literature because that is the literature. There is very little studied for adults.
And what about pharmacologic therapy versus OT? Because OT, like I said, it's so much more appealing because it's not drugs.
Right. So OT has very low evidence that it affects anything with ADHD, and pharmacology, the different medications have pretty good evidence that they help symptoms. I mean, it may vary based on the medication, but overall, they have a much stronger evidence base.
And specifically cognitive behavioral therapy is.
Oh yeah, cognitive behavioral therapy does have strong evidence, and it is currently covered.
Oh, okay. So we cover CBT, just not OT. Okay.
Yeah.
Other questions, comments?
Just take a couple notes.
Yeah.
Okay. So moving on to large GI panels. This kind of goes with our theme of different labs.
Page 193.
So this one I had pulled out as a separate review because it just has more nuances, and I thought we should go into a little bit more detail. So people who have diarrhea, which is frequent or loose stools, it can be caused by a variety of things and illnesses. There can be viruses and bacteria, protozoa, parasites, etc. Most people don't need any testing. Their guidelines do say that after 7 days with no improvement or with other concerning signs, you might want to do testing. Usually there's stool cultures, microscopy, or antigen detecting. More recently, there have been these multiplex arrays like we saw with the respiratory panel tests, but done looking for multiple pathogens causing diarrhea. And so they may be able to detect a whole variety of bacteria and viruses that may or may not be causing the issue. And their turnaround is faster. You can typically find something in a couple of hours versus 1 to 3 days required for culture. Multiplex testing, though, has some limitations. You can't take this for technical lab reasons. The samples aren't then able to be sent on to public health, where if you have like a regular stool culture and you're finding like a pathogenic E. coli, it could be sent to the public health lab for more testing for all those public health interventions and monitoring that need to be done. And it also can find, because it uses DNA and RNA, they may find bacteria and viruses that are present in very low amounts that actually aren't causing, or you wouldn't know if it's causing the pathology or not. It can find many different types of viruses and bacteria where we don't know what the clinical significance or whether you need to treat for that. And it cannot be used as a test of cure because it will find non-viable organisms. So typical culture, you have to be a living E. coli, whatever the species, and if it's been treated effectively, it may still be present but not viable. So we reviewed these panels in 2015 or 2014 because they were in 2015 new codes, because most infectious disease testing isn't really looked at in detail when they come out as new CPT codes. It was just a consent agenda. We never looked at the evidence behind them. So the specific codes we're talking about are 87505 to 87507. This uses RNA or DNA to look for a whole bunch of things that we really care about: Clostridium difficile, various types of E. coli, Salmonella, Shigella, but it can also test for many, many, many other agents. The difference between the tests are how many targets. The smallest one is 3 to 5 targets, then 6 to 11 targets, and the other one can go up to 25 targets. There are a whole bunch of there is a PLA code on the excluded file, which tests for 22 targets. And it looks for things like sapovirus, genus 1, 2, 4, and 6, Plesiomonas shigellosis, but also enteropathic E. coli and other things that we are would want to know about for either public health reasons or to need to treat. So looking at expert guidelines, in 2024, the Infectious Disease Society of America and the American Society for Microbiology came out with a guideline for laboratory diagnosis of infectious disease. They recommend not testing most patients with acute diarrhea because clinical management's not affected. These are typically, we tell people to, drink a lot of fluids, eat bland food, and it will go away on its own. They do recommend fecal testing for patients with moderate to severe bloody, febrile, dysenteric, nosocomial, persistent diarrheal illness, and for immunocompromised patients. They note that viral gastroenteritis is typically self-resolving, and therefore multiplex panels targeting viruses have little clinical impact, but it might be useful, especially for infection control purposes. Stool culture takes longer, and will frequently fail to detect the causative agents. So they actually recommend culture independent methods, which is the tests we're talking about are considered culture independent for detection of bacterial pathogens. But they do recommend stool culture when you think that this might be of public health importance. And the American College of Gastroenterology's guideline on acute diarrheal illness was published in 2016. They recommend using stool culture or culture independent methods when you have high risk, suspected outbreaks, severe disease lasting longer than 7 days, basically all the same kind of in ones as we saw with the Infectious Disease Society guideline. The traditional methods of diagnosis, the culture, microscopy, etc., fails to reveal etiology in the majority of acute diarrheal infections. So they recommend using the culture independent methods, at least as an adjunct to traditional methods. It's a strong recommendation, low level of evidence. They do note you can't use this for public health laboratory testing. And they do note that these tests detect microbes at non-pathogenic levels, and this can become quite a problem in practice. Most private payers have guidelines. Typically, they don't cover the large tests, the more than 11, unless there's specific situations, usually in immunocompromised patients. We spent about $641,000 on that 12 to 25 target testing test in the year we looked back on, 2024. So in summary, the multiplex GI pathogen panels, they are recommended by expert groups for various situations for patients with diarrheal illness. They note that it's more likely to find the causative agent and it is faster. They note significant limitations. Medicare and private insurers typically limit coverage of the large, more than 11 agent multiplex testing due to the lack of utility for most of the viral agents and some of the bacterial agents that are detected by these panels. Staff recommends removing coverage for the very large GI panels, the more than 11 agents, due to lack of clinical impact for detecting so many agents, and recommend continuing coverage of the smaller tests based on expert recommendations. So the staff recommendation effective 2/1/26 would be to add an entry to our excluded services guideline E1 only for the large test, the 87507, as well as the PLA, the U code for that 22 panel test.
And again, this is also effective February 1st.
Questions, discussion? And then if we're comfortable with that, we'll move on to, I guess we're staying with the GI track, ColoSense for colorectal cancer screening.
Page 199.
You will all recall that representative of Genioscopy, the company that makes ColoSense, came and requested a review at one of our meetings in the fall. So colorectal cancer is obviously a really important thing to detect early. There are many available ways to screen for colorectal cancer, including fecal immunochemical testing, FIT testing, colonoscopy, FlexSig, stool-based DNA testing, blood tests, CT colonography, etc. Currently, on the prioritized list, we cover FIT, FlexSig, and colonoscopy for average risk patients. We also have some criteria for CT colonography. We recently reviewed blood-based DNA testing and did not find evidence to support coverage, and we had found that the DNA testing is as effective as FIT, but far more expensive, and we don't cover that. So this test is a stool-based RNA test. So Cologuard, which you may be more familiar with, is a stool-based DNA test. This is looking at RNA, which is expressed when the genes have been expressed, and the RNA is what used to make the proteins in the cell. They're non-invasive. They don't require any bowel preparation. You just need a sample. ColoSense is approximately $500 per test, and FIT testing is about $24 per test. At our November meeting, Dr. Erica Barnell testified. She's the CEO of Genioscopy. And she testified about they have FDA approval and testified about the sensitivity and specificity, et cetera. We last looked at stool-based tests in 2021 with the USPSTF update on colon cancer screening. So currently on our preventive services guideline, as I mentioned, we cover colonoscopy, FlexSig, the FIT test, and fecal occult blood testing, and then screening CT colonography in limited circumstances. And we don't cover FIT DNA Cologuard. So the only evidence that has been published on ColoSense is the Barnell study from 2023. It was funded by Genioscopy. It's the CRC Prevent trial. They had 8,920 average risk patients recruited through social media. They all underwent RNA testing with ColoSense and then follow-up colonoscopy. And of note, when you look through they had more people than their 9,000 that actually finished the ColoSense, but you had to actually have the follow-up colonoscopy to be included. And there was a much higher rate of people failing to do the colonoscopy who were low income and people on public insurance, which would be us. So, which makes sense. It's a group that's harder to get time off of work, get healthcare, get a car, et cetera, to get to their colonoscopy. A total of 36 patients were found to have colorectal cancer, and 606 patients were found to have advanced adenomas. And 649 had medium risk adenomas. And they found that the RNA test was 94% sensitive for detecting colorectal cancer, 46% sensitive for detecting adenomas. So about 50-50 whether it could find the advanced adenomas. And then its specificity, meaning it was negative when the colonoscopy was negative, was about 88%. And they concluded that it was an effective non-invasive test to screen. Of note, this was the only trial. It was what was submitted to the FDA for approval. The FDA required Genioscopy to conduct a post-approval study with at least 12,500 participants to confirm their results. And when I went to look for that data, they began recruitment in the fall of 2025. The National Center for Health Research did a critique of this study that was published in December. They note that the area under the receiving operating characteristic, the ORAC, this is a statistical test that you would do to see whether the results would be from random chance or not. They actually found that the ORAC for ColoSense was almost exactly the same as for the FIT test by itself. So, and just one specific, this test does have a FIT test. So it is a FIT test with RNA on top of it. So their conclusion was the impact of the testing was from the FIT component, not from the RNA component. Expert guidelines, NCCN, their 2025, their second 2025 guideline does include this test. They basically say, do whatever testing somebody is willing to do. They recommend using a test like ColoSense only if that you aren't going to be using FIT or fecal occult blood testing. The American College of Physicians, their guideline from 2023 recommends FIT or the fecal occult blood testing, colonoscopy, or FlexSig. And they specifically say no stool DNA. When this was published, there was no RNA product on the market. And the American College of Gastroenterology, their guidelines was from 2021. They also recommend colonoscopy and FIT as primary. They recommend consideration of the DNA test if a patient's unwilling to undergo colonoscopy or FIT. And RNA, again, wasn't on the market at the time of this recommendation. Most private insurers consider ColoSense to be experimental. Medicare will, they will cover any test that has a sensitivity greater than 74% and a specificity greater than 90%. And based on the one trial, ColoSense doesn't meet the Medicare cutoffs. So the multi-target stool RNA testing, ColoSense, so only had one trial. There is a confirmatory real-world trial that is just commencing, so we'll have a few years before we get results from that. Of note, they had a significantly higher dropout exclusion rate for low-income and publicly insured individuals, making translation to our Medicaid population questionable. And recent critique didn't find significant added benefit to the RNA component over just basic FIT testing. NCCN recommends it, but as a second-line test, ACP doesn't recommend it. Private payers and Medicare and Washington Medicaid are not covering it. So the recommendation is to update the current guideline to include the ColoSense in our current E1 guideline, and then update the date of last review to January 2026 for ColoSense, and then specify that the review in August 2021 was for Cologuard. Questions, concerns?
I have a question. It might be stats or things I just don't understand. So the National Center for Health Research, so that area under the curve part, they were comparing the RNA and the FIT, but in the actual study, they were comparing the RNA and FIT to the FIT, right?
No, the colonoscopy.
And to colonoscopy? Well, didn't they say the RNA and FIT had a better sensitivity to specific things compared to the FIT? And isn't that what the area under the curve thing is doing? I don't understand the difference.
The study compared the results to, you had to have a colonoscopy. That was the gold standard.
Oh, okay, because at one part it says compared to the FIT, the RNA was better summary. That's why I was confused.
And
yeah, what is it, 1?
They may have said that, but the critique was that the data didn't show that.
Okay, so they're arguing over stats. So that's the part I didn't get, because they seem to be looking at the same thing, but two different people came to two different conclusions. Okay. I think it's probably moved. I'm just trying to understand. Okay.
Yeah, and the other piece I didn't mention about ColoSense is Guard markets itself as being a good screening test because they have a very aggressive patient outreach and encouragement. ColoSense doesn't have any of that piece. They don't, the company has in their materials said that they're developing it, but they don't currently have, you know, the outreach where they harass the patient to turn in their sample, which is possibly useful.
Thanks.
And I can't explain the statistical.
That's what I'm like, I
Yeah,
didn't realize that kind of could ask my wife ahead of time. Okay, thanks.
I took their point to be that they didn't think the test was much more effective than the fit component,
Yeah,
which we know is effective.
It looked like they were looking at the same thing. That was the only reason. But yes, I would kind of I would trust the independent people who are talking about complex stats more. Yeah.
And otherwise, we have one more thing with our new discussion items before we take a vote. And Heidi, do you want to go ahead?
That would be great. Thank you so much, Ariel. So I'm discussing intracranial thrombectomy for stroke. And thank you, Chelsea. So this is a topic that was brought to us by Dr. Savage, one of the chief medical officers at one of the CCOs, who was concerned that there was additional evidence, as she was right, that had come out since we last reviewed this topic. So stroke is a significant condition that results from interrupted blood flow to the brain. There's sort of two main types of stroke: hemorrhagic stroke, which means a lot of bleeding in the brain, still interrupted blood flow, or ischemic, where there's a blockage and blood can't get through. We are talking today specifically about ischemic stroke, where there's a blockage that prevents blood flow in a large vessel to the brain. We know that stroke can have a lot of lasting impacts. If people survive a stroke, there's also a lot of potential for morbidity or problems related to the stroke. So in recent years, there's been a lot of development of interventions that actually address the area of the blockage. So endovascular is the term, meaning that the technique actually goes into the blood vessel and removes the clot. And there are a couple different ways that that can happen. We're specifically talking today about cerebral, so brain clots, and we're specifically talking about interventions that are a therapy for an ischemic stroke in a large blood vessel that goes through the blood vessel to remove the blockage. So this, presumably, if done early in recognizing someone's having an ischemic stroke, increases outcomes. So that is really what we were taking a look at. This is an emergency procedure. It's going to be done within hours of stroke onset. Hopefully people are arriving in that time window, and you'll see in some of the evidence that they indicate some time windows in which this can happen. The other thing to note here is that this EVT, which is the abbreviation I'll use for the rest of this, just to spare you hearing me blurt out a lot of jargon, but the endovascular therapeutic intervention, the EVT, is considered minimally invasive, even though you're inside the blood vessel. You're using a catheter. The clinician is using a catheter, and it is considered to be less invasive and less complicated than an open procedure that might be also taking a blood clot out, but this going through the catheter seems to be less invasive. So you can see that we're looking here at the previous HERC review in 2015. And so the evidence that you're going to see that I present today is what's been come out in the last 10 years since that review. Currently, we do not cover endovascular therapy for stroke. It is through the 2015 review put on the E2 excluded services guideline. And at the time, it was thought that there was no evidence of effectiveness. So you're going to see the additional pieces of evidence we have here in a moment. So because this is a pretty technical procedure, I provided you with a little table of terminology, and I'm just going to briefly run through it because some of it's relevant to the evidence that you're going to see in a moment. So there's a early CT stroke score, and my goal here is just to make this accessible to everyone. So these just describe things that are in the evidence to help you understand what they use to actually assess whether someone was having a stroke, what it looked like, and then also whether there was the right inclusion for this particular procedure. I've already talked about EVT. there are two large vessels that are primarily focused here. So large vessel occlusion means a blood clot in one of the big blood vessels that supplies the brain. So a clot in one of those two big blood vessels is often what leads to this, and that is where this particular intervention would be targeted into one of those two large blood vessels. Those two are primarily the internal carotid artery and the middle cerebral artery. So not to get too much vascular anatomy here, but want to make sure everyone is grounded in what we're looking at. And then finally, the primary studies for this since 2015 really focus on what's called a modified Rankin scale. And it is a 6-point scale that really looks at a degree of disability. And so this is really the primary outcome that we were looking at in these primary studies. And so a score of 0 is no symptoms. 1 is that the person who's having the stroke has no significant disability despite having a few symptoms, but they can still do their normal activities. And then it goes up subsequent levels of disability to 5 is severe and 6 is deceased. So this is just to orient you to the data you're about to see. Staff identified 6 randomized controlled large vessel occlusion stroke trials since the last HERC review in 2015. We've listed out those trial names for you there. This little box right here is just a summary of those primary studies, and then I'm going to walk you through some meta-analyses, systematic reviews below that utilize these studies. Essentially, recruitment for these studies in aggregate occurred between 2018 and 2023, and the intervention and control was endovascular therapy versus medical management that occurred within 24 hours of the stroke symptom onset. Inclusion criteria was for adults 18 and over, and importantly, the initial modified Rankin score was 0 to 1, meaning there was no disability at all or was a slight disability but still able to perform activities. And it needed to be in one of those large vessels. Primary clinical outcome was, again, looking at that modified Rankin score at 90 days. Some of these trials did follow out to a year, but most of them predominantly looked at that first 3 months. And then safety outcomes were also a big component here and wanted to be sure that we discuss that too. Symptomatic intracranial hemorrhage, so meaning there's a bleed in the brain that someone's experiencing symptoms from within 24 to 48 hours after that procedure. Then also looking at mortality both at 3 months and at 12 months or 1 year. So from those primary studies, those 6 randomized controlled trials, there were a number of meta-analyses and systematic reviews. You have several of them here. So the first one I included, staff included all of the trials that were a part of each of these systematic reviews. And you'll see that in the first one, published in 2024, they looked at about even controlled and EBT. That in the medical management was the control here. Clinical outcomes, the EBT group had a lower MRS, meaning lower disability score, so lower is better than medical management alone, demonstrated higher rates of functional independence at 3 months post-procedure, and then also higher rates of independent ambulation 3 months post-procedure. From a safety perspective, they found that there were higher rates of intracranial hemorrhage with EBT compared with medical management and similar all-cause mortality. Their conclusions were that there's efficacy for EBT for acute ischemic stroke with a large vessel. In the second one, they utilized 4 of the randomized controlled trials listed above, and you'll see it was just a little bit less, 650-ish people in both groups, again, controlling for best medical therapy. The clinical outcomes were similar, so EBT was associated with reduced disability at 3 months and improved ambulation at 3 months as well, and functional outcome at 3 months was better. From a safety standpoint, they did also recognize higher rates of intracranial hemorrhage with EBT and similar all-cause mortality. Their conclusions were from this meta-analysis that the EBT is safe and effective and may be considered in everyday clinical practice for those large vessel ischemic strokes. Staff took a look at expert guidelines. So the first one is from the guideline from the Society of Vascular Interventional Neurology. They recommend the use of this in early intervention. I did list out the levels of evidence for you there as well for each of the recommendations that they had, but essentially having a large vessel ischemic stroke and having an early onset and a baseline where you don't have a lot of disability at the beginning when the stroke initially occurs. Their early intervention has a good recommendation for using EBT as opposed to medical management. The American Heart Association, American Stroke Association have a combined recommendation that they recommend with the following criteria. So again, that modified Rankin score is low, which means there's no to very minimal disability. Occlusion in the large vessels. So again, those two vessels I talked about earlier, adult. And then there are some other scores here. I mentioned the one of what it looks like on imaging or on CT. And then, of course, early intervention. So within 6 hours is their recommendation. We took a look at a couple payer policies. Aetna is considering it medically necessary for persons with acute ischemic stroke who have that anterior occlusion when it's performed within 12 hours. The Anthem recommendation is also listed out there. And I included the whole thing so that you had, it's a little bit more granular, but the recommendation that they use is for coverage. So we did not get any expert input, nor did we get any public comment on this. Our recommendation is, well, the summary is that since the last review in 2015, there is significantly new evidence that using EVT can be safe and effective when given early and people have a limited disability at the onset of stroke. And that we would recommend adding coverage for cerebral endovascular therapy to line 314 for stroke, specifically ischemic stroke, and that we would remove it from guideline note E2, which is the excluded services. You'll see also the 2027 recommendation there as well. So any questions, discussion?
All right, I don't see anything. Thanks very much, Heidi. So we are going to now vote on the entire set of staff recommendations and block. Does anyone have any further discussion before we vote?
It's all staff recommendations with one guideline modified and yeah.
Yeah. Okay, I entertain a motion. So moved. All right, do we have a second?
Second.
Thanks. You're Denny and the duo, the two of you. Thank you. All right, Daphne.
You bet. Antoinette, a watch.
I approve.
Thank you. Mary Beth Ongrove.
Approve.
Ben Hoffman. Adrian Irwin.
Approve.
Max Kaiser.
Approve.
Lucy Langer.
Approved.
Sarah Love.
Approved.
David Sanger.
Approve.
Mike Collins.
Approve.
And Brian Duty.
Approved.
Motion passes. Thank you.
All right, thanks everyone. So we're now going to move on to the 2027 CPT code early review with Ariel.
Yeah.
Page 214.
So I just want to preface this whole discussion with a couple of comments and questions maybe. So we, as a rule, do not review the CPT codes that end in T. We affectionately call them T codes. They're temporary. They're typically given by the AMA for a technology that is up and coming, but we don't review them routinely. We have reviewed, actually you just saw one with the keratoconus, that if there is a procedure or a service that only has a T code that does have evidence that we do want to cover, then we will review them and either explicitly cover them or explicitly not. Otherwise, OHA has all of them turned off. We don't pay any of them. These are all T codes that we're going to look at, so we normally wouldn't study them. The AMA creates CPT. They all come out in the fall. We had a lot of trouble this year getting the codes. We anticipate we're not going to be able to get them until late October again in the future. So what I have been doing is reading all of the minutes of the CPT editorial committee. Wow. Yeah, it's great. And I have pulled out things that they are retiring a T code and giving it CPT code so that we can review them early. The ones that you're seeing today, the recommendations are all non-coverage, which would be consistent with what we do with T codes. In March, there are a couple that we we're awaiting a final evidence review that's coming from NICE, but anticipating they're gonna be consistent with what I've already found, we will want to cover them. So then we just need to start thinking as a group. I think if we're reviewing a new code and we don't want to cover it, I think that is fine. And then what the plan will be is when those CPT codes are reviewed and they're published in the fall, I will go back, make sure that they are still consistent with the T code. And if there's anything between now and October that's really groundbreaking, then we can re-review them. Otherwise, we'll just substitute in the new code where the T code went. For the codes that we do find evidence for, assuming we will, I think this isn't today, but in March, we may have to have more of a discussion. Do we just kind of say, yes, we probably want to cover the CPT code, let's wait till the fall, or do we want to start covering the T code? We don't have to make a decision about that yet. I just wanted to bring it up for your all to mull over. Probably matters a little bit more to the CCO folks than the other folks. But anyway, so partly to address anybody if you're saying, why are we looking at T codes? Partly just to sort of cue you that we're gonna probably have a shorter review of CPT codes in the fall, just a lot more time compressed, so.
Eric, are we talking to people to change the OAR though? Because the OAR says we only cover certain types of T code.
The OAR, I believe, we've had some meetings with folks about it. I think it says if we specifically act.
No, it's specific to ABA.
Yeah, it says we don't cover them. We can cover them. I have the
So we should-
every day. We can cover ABA, and then we don't cover them otherwise.
We should keep on them about that.
Yeah, we have had conversations about changing it to unless HERC specifically acts.
Yeah.
But yes, that is the current one. It's just the ABA. But there are several that we have on the prioritized list.
I know, but it'd be nice if they were consistent, that our rules agreed.
Agreed.
Yeah.
And we don't write the rules, but we can have input with the folks that do. So thank you for the reminder. Okay, let's see. Going into this, irreversible electroporation of pancreatic tumors.
Page 214, are you still going?
No,
on?
that's great.
Sorry.
For those of you who remember the fall, we actually looked at this irreversible electroporation for liver and prostate. So this is using an electrical current to destroy a tumor. And it's proposed for areas where you want to be very precise because there's a blood vessel or a nerve or some important structure there. And so this one is specifically looking at the irreversible electroporation for tumors of the pancreas. It currently has 2 T codes. They're proposing a new CPT code that would be effective January 1st, 2027. For pancreatic IRE, there was a systematic review published in 2025. They found 2 RCTs and 36 prospective or retrospective cohorts or case series that either compared IRE to standard of care, or didn't really say what they were comparing it to. 36% of patients had an adverse event. 47% of the adverse events were severe. So like 15% of people had a severe adverse event. The most common was pain. Some had ascites, pancreatitis, biliary or pancreatic fistulas, infections, hemorrhages, and 25 patients died as a direct consequence. And the median overall survival after IRE was 17 months and progression-free survival was 12 months. Unfortunately, pancreatic cancers tend to be very poor survival overall. And when you specifically look at overall survival of IRE compared to FOLFIRINOX, which is a typical chemotherapy agent, or the overall survival for patients who did not have any surgery after chemotherapy, it didn't appear to extend survival significantly based on just people who had kind of more standard of care. there was one RCT that wasn't included in the systematic review that was published in 2024. It's the Crossfire trial. I'm sorry, it was included in the systematic review. I pulled it out just so we could look at it in more detail. They compared IRE to stereotactic radiotherapy, and all patients had already had the FOLFIRINOX chemotherapy. They had 68 patients, 34 in each group. Median overall survival was 16 months in the ablative radiotherapy group and 12 and a half months in the IRE group. And it was stopped early due to futility, although it actually seems like it showed that IRE is less effective. I guess if it met their criteria that it wasn't more effective. And we actually don't cover that stereotactic ablative radiotherapy because of lack of evidence currently. So it's kind of comparing two experimental things to each other. The NCCN's latest guideline on pancreatic adenocarcinoma, they state, due to concerns about complications and technical expertise, the panel does not currently recommend IRE for treatment of locally advanced prostate cancer. It's not in their treatment algorithm. Pretty much everybody else feels that it is experimental. NICE specifically says it's you can only use it in context of research. So in summary, the evidence to date on irreversible electroporation for pancreatic tumors consists mostly of cohort studies and case series. There's concerning complications, including a significant number of deaths have been reported. NCCN does not recommend it, and no private payer is actually paying for it, and NICE specifically calls out that this is experimental and is concerned about the complications. So recommendation is non-coverage. So we would put the T codes in our excluded services guideline E2, which effectively wouldn't really have any impact currently. But when the new CPT code is published, we will replace it with a cursory review to make sure that there's nothing groundbreaking. Questions?
There's a typo on her stuff and it's saying SBIRT is not covered, and it should be SBR, I think. Pretty sure we still have SBIRT, but yeah.
If you have pancreatic cancer, you're beyond SBIRT.
Beyond SBIRT, yeah. We're under the Timber 2024 G staff notes.
Thank you. Yeah. We do cover SBIRT, which is a screening for substance use.
Yeah.
Okay. Thank you. The next one is cardiac contractility modulating systems.
H217.
So this is a therapy that's proposed to treatment for people with moderate to severe heart failure. Interestingly, nobody really knows exactly how it works, but it is FDA approved. The FDA labeling requires patients to be in normal sinus rhythm with a left ventricular ejection fraction of 25 to 45%, and you're not being considered for cardiac resynchronization therapy, or CRT. So again, the mechanism is not really known. It's hypothesized to improve calcium metabolism in the cardiac cells and reduce fetal gene expression and reverse cardiac remodeling. So it essentially acts to improve how strongly the heart muscle contracts without increasing the oxygen load. So when your muscles move, you typically need more oxygen, which is why you breathe harder with exercise. And so this is proposed to help the heart beat more strongly without needing higher oxygen demand. There are other treatments for severe heart failure. The most common is cardiac resynchronization therapy with a biventricular pacemaker and an implantable defibrillator. So these are people who, it's like a pacemaker put in, but when your heart goes into a severe abnormal rhythm, it automatically shocks them. And you may not be a candidate for that type of therapy for various reasons, and that's the population that we are looking at for this new cardiac contractility modulating system. We have never reviewed the codes because they are T codes. So there was a comprehensive review of the literature published in 2024. There are essentially 3 studies: the Fixed Heart Failure 3, 4, and 5. Fixed Heart Failure 3 was a cohort study of 25 patients that showed statistical improvement in left ventricular ejection fraction, 6-minute walk test, and a quality of life score. Fixed Heart Failure 4 was a randomized double-blind crossover study of 164 patients. And there was crossover. So everybody had the device implanted, half had it turned on, half had sham, and then they crossed them over. And they found a statistically significant improvement in peak VO2 and 6-minute walk score in the group that had it turned on compared to the sham. The Fixed Heart Failure 5 was an RCT of 428 patients with a left ventricular ejection fraction of less than 35%, so New York Heart Association class 3 or 4, despite optimal medical therapy. They were either optimized to continuing optimized medical therapy or to the device, and they found peak VO2 and the walk score were higher in the device group. There was a subgroup analysis that was published in a different study looking at 160 of the patients, and they found no difference in overall survival or hospitalization rates. But they did find the combined outcome of survival-free of cardiac health and heart failure hospitalization was significantly better in the device group. So essentially what I take from those 3 studies are there's some intermediate outcomes that might be slightly improved with this, but not really the long-term patient-oriented outcomes like survival and hospitalization. There was a meta-analysis of these studies, the 3, 4, and 5, and found no significant difference when you have the device plus optical medical management compared to people with optical medical management alone in terms of hospitalizations, arrhythmia events, total hospitalizations and overall mortality. And then if you combine all the data, there was no significant difference in the 6-minute walk test. But they did find a significant improvement in quality of life based on the quality of life and heart failure score. But they note that the clinical relevance of that improvement in the quality of life may not be, so it was statistically significant, but might not be clinically significant. Expert guidelines, the American Heart Association, American College of Cardiology's guideline from 2022, they talk about cardiac contractility modification and note who it's been FDA approved for, but they note that there is no benefits to death or hospitalization, and it's not listed as a treatment option. In a, they have a 2025 guideline about who you need to put these implantable cardiac defibrillators and resynchronization and all of the things that we do and we currently cover. And they note that the contract modulation system may be considered for people who can't have that sort of definitive, the cardioverter defibrillator. And they note there's no current practice guidelines that actually recommend the cardiac contractility modification. Like they note that the lack of guidelines likely reflect the strength of evidence related to hard clinical outcomes such as hospitalization and mortality. Most payers don't cover this, or Medicare is covering it with evidence development only. So in summary, cardiac contractility modulation, it's been studied in 4 RCTs with approximately 400 patients who had the device inserted. The meta-analysis shows statistically, but probably not clinically significant improvement in quality of life, but no difference in outcomes that we would really value, such as death or hospitalization, compared to optimal medical therapy. It's a maybe considered in the American Heart Association guideline, and everybody, all the payers and Medicare essentially considered experimental, although Medicare will cover it as part of evidence development and registered trials. So again, recommendation is guideline E2, and then with the new codes being inserted when they're available.
I love that they don't know how it works.
Yeah.
I'm just always astonished when that happens, but it does, not infrequently.
They have some great theories. Like, I didn't realize you had fetal DNA expression, and yeah,
It took a long time to figure out why cardiac resynchronization therapy works. I think we still don't really know how that works. And that is really well established. I would say, just as the cardiologist here, I've never even heard of this. This is really out there. I mean, I read all the journals about cardiology, and I go to conferences, and this is new to me. But I mean, it's appealing. It's interesting. I can ask my heart failure expert friend. I have a friend who's a heart failure expert, and I'll ask him and get back to you. But I don't know.
Right, and again, if you have experts that come back, or we have any other data between now and October-ish, we can definitely take that into consideration.
Yeah, I'm not. This is my last meeting, but feel free to contact me anytime. I'm happy to provide advice.
Great, thank you. I will take you up on that. Okay, our last new CPT code-ish is fluorescent wound imaging. So this is a test where they
Thank
you. They use an ultraviolet light, and it kind of makes your wound glow if there's bacteria present, so it can help you detect wound infections. And it's proposed that would improve wound outcomes. There's currently only one device that does this. It's FDA approved in the US. So standard care for diagnosing wound infection is a bacterial culture, which could be done either with the traditional culture plate or some of those DNA tests we were talking about earlier. But many times wound infection is just diagnosed based on clinical, you've got pus, warmth, redness. You might do the culture just to see what the sensitivities are, in which case it's important to actually do the culture, because then you actually grow the bacteria and you can see which antibiotics would work, which can't be done on a lot of the other tests. So looking at this technology, there was a systematic review in 2025 of 17 studies, 834 patients, some non-randomized clinical trials, case reports, observational studies. Most were diabetic foot ulcers or venous leg ulcers, some were burn wounds. The autofluorescence or fluorescent imaging sensitivity was 45 to 100%. So, I mean, that would be worse than like your clinical impression, and sensitivity is 55 to 92% for detecting bacterial burden in wounds. Positive predictive value was 64% to 95%, meaning if it looked infected, you had a 2/3 to almost 100% chance that it was infected. Negative predictive value, meaning if it didn't look infected, it really wasn't, was 35 to 100%. It exhibited greater sensitivity than general clinical exam, particularly in wounds without overt clinical signs. And it helped to guide the swabs to know where in the wound to swab to get the bacteria. So their conclusions were that autofluorescent imaging enhances wound assessment by improving bacterial detection and may support more targeted clinical interventions, but more research is needed to clarify its impact on infection control and long-term healing. There was a review article in 2021 about how to diagnose wound infections. They listed a whole bunch, PCR, microbial DNA, presepsin, which is a laboratory marker. They did note that autofluorescent imaging is an innovative approach that's kind of up and coming. They note that it cannot detect infection in all causative microorganisms because you have to have a porphyrin. So if you have some bacteria don't have the substance that fluoresces, so you're going to miss some important bacteria, but it can be used to find hot spots in wounds, which might help you know where to culture. NICE looked at this in 2020. They only found 7 observational trials. They were all of the moleculite system. They found low methodologic quality. There were small sample sizes and limited range of outcomes. There was lack of evidence on things that we care about, like wound closure time and effective antibiotic usage. They recommended large RCTs should be done, and they should look at things like wound closure, number of antibiotics used, etc. Everybody considers this experimental that I could find policies written for. So in summary, fluorescent wound imaging is a new technology, hasn't been widely studied. Does not appear to be any RCTs to date, comparing it to just routine wound culture testing. And there is no literature on outcomes such as wound closure time, number of antibiotics used, or other patient-important outcomes. No other payer survey is covering the technology. So again, recommendation would be guideline note E2 with update in the fall. Questions, discussion? And then just a little feedback to me. This is really helpful for me in terms of what's going to come in the fall. Is this helpful? I mean, do you feel like it's worthwhile to be doing these early reviews? Okay.
This is the most fun part of the whole agenda.
Finding out things the cardiologists don't even know exist.
Yeah, I don't feel bad about not covering something. Yeah, cardiologist doesn't.
Yeah, going through the AMA meeting minutes is interesting. It seems like if you have a strong advocate,
yes,
they will consider giving you a CPT code.
That's fair. I've seen that too.
And then they do things like they're taking all of our maternity care codes away, giving us a whole new set, all the bundled codes.
Mm-hmm.
Yeah.
Just to underscore that, you already said this, Ariel, but this is a 2027 code.
Yes. Well,
And
these are 2025, 2026 T codes.
Okay, but
And the T codes will show up in E2, but it's not really going to have any impact because we already don't cover those codes.
Does every T code become, like, do they grow up to be a real CPT?
No.
Okay. Some of them, that's good.
Stay out there.
I just know that process.
Yeah. For our March, I just reviewed one that they published a new code for 2026 that was a T code, and they're going to convert it the year later to actual code.
Yeah.
That was one I just reviewed a couple days ago. Some of these, like the corneal cross-linking, it's been a T code for like 15 years.
Okay.
yeah, and this should help our November meeting and allow more public engagement for manufacturers and interested parties. Since we'll be doing it earlier, we'll be giving more notice than we have in the past.
And we can go into a lot more detail because usually those fall reviews are pretty abbreviated.
Yeah,
Just
so
because of the volume.
really appreciate Ariel coming up with this idea to stock the AMA's minutes. Heidi, looks like you have something to add.
I just wanted to add the importance, really trying to just make sure everyone understands, public included, that even though they are maybe converting from T codes to CPT codes, that doesn't endorse medical necessity, and it's still critical that we look at the evidence in detail. So we often get feedback that, well, there's a CPT code, so it must be medically appropriate in X scenario. And so I just wanted to highlight that too while we were talking about this.
Yeah, and just as a feedback to you all, there's a couple of cardiac valve. Actually, maybe I'll bug David about this. The ones I was looking at for March, we typically do these intravascular valve replacements for like the aortic valve. They're looking at it for tricuspid. And if that is more as effective as open heart surgery, we may actually want to cover the T code before it becomes a CPT code. Although it will be covered for 3 months.
Some of these are approved now. A lot of these are actually standard care, like tricuspid clip has been out now.
Maybe it's not trach, it's pulmonary. I'm sorry.
Oh, okay. Yeah, it
Okay,
depends.
which
It all depends. There's new stuff coming out all the time, but I'm happy to help. Sure.
Yeah, this is not on the agenda today. This is, and NICE is coming out with a review in a couple weeks, and they tend to be highly evidence-based. And if they're recommending coverage, I think we would all be comfortable.
Okay, yeah.
Mary?
Hi, thanks. I apologize. I missed who just made the comment about the issue that CPT codes come out and there's kind of this assumption that, okay, this is a new code, it must be covered. But I really appreciate that comment, and also the difficulties identifying new codes that come out every year and trying to track those and get a list of those. And one area that we talked about earlier where this has really been a problem is with the skin substitutes. I don't know if others have ran into that, but besides the huge fraud issue, there's also been issues of new manufacturers that aren't doing appropriate and safe testing for infectious disease. And I'm sure you've all read about that. But yeah, so thanks for the work on identifying these codes. And I wish there was some way to make it easier. We've had a couple come out that we've missed, and it's just been like a lot of consequences from that. So just wish there was an easier way, but appreciate the work.
I always invite this, but if you do find a code, like in those infectious disease lab codes, there were a whole bunch that we just we don't review a lot of the lab tests in the past because we had limited bandwidth, but hopefully we can do more of that.
Another comment, you brought up coverage with evidence generation, and maybe just because my day-to-day reality is across Medicare, Medicaid, and commercial, but test developers and device developers will come and say, well, it's covered. Medicare covers this. And that's sort of a falsism that we need to be careful about when we're thinking about who covers and why. Commentary.
Great. So you do need to take one more vote just on these 3 early codes. Again, not a lot of actual impact currently, but hopefully I really appreciate that you're letting me do this because my burden of work will be much more spread out over the year than like highly concentrated in the fall.
I don't feel like we're letting you, we're doing your service. You do your job. This is great. Thank you.
I make a motion to adopt the recommendations.
And as always.
Dream team. All right, Daphne. Is she frozen?
She looks frozen.
Oh, she may have lost her internet. I'll go ahead and call the roll here.
She has a great poll.
Yeah, it's much better than usually, like picking my teeth, picking my nose.
Oh, she's back.
Oh, she's
Right
back.
here.
Okay. You froze for a minute.
You were frozen.
Aww. Antoinette election.
I approve.
Wonderful. Mary Beth Ongrave.
Approve.
Ben Hoffman.
Approve.
Adrian Irwin.
Approve.
Max Kaiser.
Approve.
And she's frozen again.
Lucy Langer approves. Sarah Love approves.
Sarah, Lucy approved. Anybody, Kaiser, Love?
Collins.
Mike Collins?
Mike approves.
David Singer.
David
Sanger.
Sanger.
Yeah, I
Collins
approve.
and
Yes.
Duty.
Sure.
And what about David Sanger?
Yes.
And Brian Duty.
Approve.
All right.
All right, great job. Any other new business or any comments or questions? Otherwise, the next meeting is going to be a hybrid format with the location to be
TBD, correct, March 19th.
March 19th. Yep.
Ooh, I have something.
Fire away.
If I'm not frozen.
No,
I have an
you're-
announcement if I'm not frozen. We're having a listening session. It looks like the January one might not come off, but March 5th for members and providers. Unfortunately, not you guys, but if you could help me spread the word, I will send an email out to everyone.
Thank you, Daphne. Like we've been doing those for a couple years here and we've had limited interest, but those are a great time. If there are more complex issues that can be discussed in a public meeting and you're aware of a provider,
A patient, a family member.
anybody, who needs to discuss
Anybody
an
but
issue.
you. You can't come.
You kind of ask me anything for Ariel, so, yeah.
Except for changing rules, changing amount we pay,
except for things we can't control, the things that.
Just have people go ahead and sign up and then I'll talk to them.
Okay,
Well,
thank
you for
you.
being so efficient today.
Yeah, appreciate everyone.
Yeah.
And we'll go ahead and pause the webinar and come back on at 1:30 for her.
I'm going to put up a note that says we've adjourned and etc. So when people come on.
Thank you, everyone.
Thanks.
Dr. Sanger, it's been lovely working with you.
Oh, thank you very much. Yes.
Wish you well.
Thank you
very
for
much.
listening.
Thank you.
Bye-bye.
Bye.
Everyone.